Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day today. We got a great episode in store for you all. And this episode is on essentially mastering some of the foundational topics in intensive care unit medicine, some of which that are pertinent to rounding as well. So this is really well targeted for those who are newer to the ICU or those who just want to brush up on some of the fundamentals. In this episode, we're going to build a practical framework for how to think, present, and manage critically ill patients. Again, targeting maybe those who are having their first month in the ICU. We'll cover how to present mechanically ventilated patients on rounds, understanding some of the basic ventilator settings, interpreting ABGs and VBGs, approach to stress ulcer prophylaxis and enteral nutrition, and ultimately assess readiness for extubation. Whether you're a student, a resident, fellow nurse, RT, attending, looking to strengthen some of these fundamentals, the episode is designed to help connect these concepts, these really kind of fundamental everyday concepts, into a cohesive workflow with a good comprehensive understanding of them. Quick shout out to our Patreon community. If you have not heard of this, we've been spending a ton of time growing our Patreon emergency critical care medicine community, and we've been so grateful. There's been a ton of interest in it. We got study guides and mini courses and practice tests, medical education posts, ad-free videos. It's becoming one of the probably largest collections of emergency critical care medical education out there. So if you have an interest, it's linked in the episode description as well as the pinned comment on YouTube. We would love for you to check it out and let us know what you think. No further ado, though, let's dive in. So today we are going to be talking about how to present a patient on mechanical ventilation on rounds at the hospital. This will be interesting for anyone who works in the clinical arena, whether you be a student, trainee, or anyone who just is presenting on rounds or thinking about how to present on rounds or wants to even figure out how to maybe teach how to present on rounds. In addition to that, it could be interesting to the general public too, for those interested in loved ones who unfortunately found themselves on mechanical ventilation and some of the things we think about. So the goal here is to show everybody how to thrive, how to impress on ICU rounds. We haven't done a video or a podcast like this before, so certainly let us know what you think, if this is helpful and interesting, or if it's a complete and utter waste of time. We hope it is the former, not the latter, but obviously we do all this to try to help out you all, so if it is not helpful, we definitely want to hear that. We will upload this as a study guide to our Patreon page. We'll put up some practice questions too. Early access on our YouTube members page, and then as just a friendly reminder and shameless plug, we do have that weekly newsletter that we put out as well. And then you might be listening to this as a podcast, because we're podcasting now, or you might be watching it as a video. So either way, we appreciate you. No further ado, how to present mechanical ventilation on rounds. So the start of this tends to be with an organization or a structure to how you want to present the different parts of relevant data related to mechanical ventilation. So you have a patient and they are intubated, okay? Maybe is it a sad face or a happy face? I guess we'll say it's a sad face. And you are the one pre-rounding on them. You need to collect certain data. And the data you need to collect on pre-rounds is actually a lot, and this is a robust, right? There's a comprehensive look. Not saying you got to present this on every patient every time on rounds, but this is kind of a comprehensive approach. And the data you really need is you need to know their mode of ventilation. Are they on volume control? Are they on pressure control? Are they on something different like pressure support? Maybe they're on an SBT trial. You need to know their ventilator settings, particularly things like PEEP, FiO2. All right, is it volume control? What's their tidal volume? Or are they on pressure control? What's their inspiratory pressure? You need to know the respiratory rate. Depending on their physiology, sometimes you need to know things like I to E time. We're going to talk more about all this. Then you do need to know their peak and plateau pressures. Recent arterial blood gases. What your goals are is important to know and have. Recent chest x-ray findings, and then what you want to do with all that great data you collected. All right, so that's kind of the basic foundations of data collection. These are the things we're going to be talking about in terms of how to collect the data, how to think about it, and how to present it. So if we start with number one, mode of ventilation. The common modes to know, and we've talked about this in the past. We got tons of videos on mechanical ventilation linked in our mechanical ventilation playlist, so check those out if this is confusing. But the common modes to know are volume control and pressure control. These are the two main modes of mechanical ventilation that we use. Pressure support is important to think about too if they're on it, right? spontaneous breathing trial patients, when you're trying to liberate them from mechanical ventilation, often have a pressure support trial. SIMV people still talk about, but this is not commonly used, so we're going to cross it off there. So the two main ones with kind of a third possible that you need to know are volume control, or pressure support. So if you're on rounds, it's important to start with, patient is on volume control, or patient is on pressure control, or patient is on a pressure support trial, right? So that is number one mode of ventilation. Number two is going to be ventilator settings. Okay, and there is somewhat an order to this madness. People probably don't really care too much about the order, but there is some degree of formality to the order, which we'll talk about. But ventilator settings are the next thing to know. So you already identified maybe your patient's on volume control. They're on AC, VC. All right, now what settings are they on? And the settings to think about are respiratory rate, tidal volume. If they're on pressure control instead of tidal volume, you need to know your inspiratory pressure, and then your FiO2, your PEEP, and I to E ratio sometimes, which we'll talk more about in a second. Okay, but when you're thinking about this on rounds, usually we have respiratory rate followed by tidal volume, followed by FiO2, followed by PEEP. Okay. When you do present their tidal volume, if you want bonus points, you can say what cc's per kg of ideal body weight it is. So this might look like, patient X is on ACVC. Ventilator settings are 18,450, which is about 6 cc's per kg of their ideal body weight. FiO2 40%, PEEP of 8. If someone has obstructive lung disease or kind of a deranged I to E ratio, normal being about 1 to 2, it is important to say that because these things can get lost track of sometimes. So let's say they're on an I to E ratio of 1 to 4 because they have a bad COPD exacerbation. You can then add that I to E ratio at the end, right? So patient X is on ACVC. Mechanical ventilator settings are 18,450, which is about 6 cc's per kg of ideal body weight, FiO2 40%, PEEP of 8. Their I to E ratio is still 1 to 3 for their obstructive lung disease. Okay. If you have a attending or someone who's thinking about stuff and they're really quick, sometimes they don't even want you to label things. They just want you to say 18,450, 40%, and 8, just in this order, rather than saying PEEP of 8, FiO2 of X, tidal volume of X, and respiratory rate of X. But that's somewhat person dependent. It's always easier to start by saying what things are, and you can always take out those labels if that's what people prefer, right? So maybe say patient X is on volume control with a respiratory rate of 18, tidal volume of 450, that's about 6 cc's per kg of ideal body weight, FiO2 40%, PEEP of 8, their I to E ratio is still 1 to 3. All right? You still with me? So we've done 1 so far, mode of ventilation. We've done 2 ventilator settings. Let's keep stacking on. So peak and plateau pressures. This is the next thing, and this is starting to get next level. A lot of people can do 1 and 2 with the mode of ventilation and settings. But once we get to 3, this is where we really start to impress and start to really understand things a little bit better, which is important too. And the pressures you're most interested in are going to be the peak pressure and the plateau pressure. And remember, the peak pressure and plateau pressures, this is really for volume control settings. You can't really get, it's not easy to get accurate numbers if someone's on pressure control. So this is for volume control settings. All right, the peak pressure differs with each breath, and it's usually shown on the ventilator screen somewhere. So every time a breath's pumped in, often it might be in the top right corner. You got kind of your ventilator screen. You might get your peak pressure up in this top right corner, but it depends on the brand of ventilator that you have. But a range is okay. Let's say their peak pressures have been kind of 30 to 40. All right, write that down and record that. Then their plateau pressure. Their plateau pressure, you actually have to do an inspiratory hold maneuver. Not that we are suggesting you should go do a bunch of stuff on the ventilator. Certainly make sure you're following whatever protocols your institution has. This is often recorded in the chart by respiratory therapy every so often. But you can do it bedside too. It's really easy. You just do an inspiratory hold. Okay. And then when you do that inspiratory hold, it'll usually pop up somewhere on the ventilator screen as plateau pressure. All right, and that's a singular number. Let's just say the plateau pressure is 24. Okay. The last kind of pressure that can be important to document and to present, and this is really next level, is the driving pressure. And we don't want to go into what exactly driving pressure is, but it is a surrogate for possible kind of optimal PEEP, and the goal is less than 15. All right, the goal plateau pressure is less than 30. The goal peak pressure, there's some variability here, but less than 40 is probably a reasonable number. So if we were to present 3 peak and plateau pressures, you know, you might say something like peak pressures have ranged from 30 to 40. Plateau pressure this morning was 28, and the driving pressure is 14, or the driving pressure is 20. All right, and if you were to connect all those, now we got 1, which is mode of ventilation, we have 2, which is settings, and we have 3, which is pressure. And you might say something like, patient X is on volume control. Their current settings are a respiratory rate of 18, tidal volume of 450, which is about 6 cc's per kg of ideal body weight. Their FA2 40% is their PEEP of 8. Their IDE ratio is still 1 to 3. Their peak pressures range this morning from 30 to 40. Their plateau pressure, when I checked this morning, was 28, and their driving pressure is 14. All right, things are getting a little more tricky. But yes, peak and plateau pressures are the next things to add on, and then driving pressure is a nice bonus. This is particularly helpful if you have a patient in ARDS, okay? All right, step number 4. Now we're gonna add on the arterial blood gas. Now, this is something that should be reported, in our humble opinion, when you're presenting mechanical ventilation. It might come up in your plan elsewhere too, but when you're presenting data, the most recent ABGs, important to know. You don't necessarily need an ABG all the time for each patient, but the most recent ABG, if it's within the last 24 hours, is important to present. And typically we present the pH, the PaCO2, right, which is the partial pressure of dissolved carbon dioxide, the PaO2, or the partial pressure of dissolved oxygen, and the bicarbonate comes on the ABG2. We personally don't usually present the bicarbonate, but you certainly can. And the SpO2 and the pulse ox can be relevant. You could present that too if you would like. The order in which these are presented is usually pH followed by PaCO2, followed by PaO2. And if you do bicarbonate, bicarbonate's at the end, although again, we don't tend to do bicarbonate. So you might say, if you're presenting the ABG, is most recent ABG was from 3 hours ago, the pH was 7.34, PaCO2 is 48, or PaO2 is 82. If you really want to go quick and you want to take away the labels, you just got to make sure that everybody knows what you're talking about. But you could say something like, the most recent arterial blood gas was done 3 hours ago. It demonstrated 7.34, 48, and 82 would be a reasonable way to present that too, as long as everybody's on the same page, which not everybody always is. All right. When you are interpreting this, just remember that the PaCO2 is a marker of ventilation, which is respiratory rate and tidal volume. The PaO2 is a marker of oxygenation, which is usually PEEP and FiO2. And we'll talk a little bit more about that. So we're going to stack all these together. Hopefully we don't start to forget things. We certainly might. But you can say patient X is on volume control. Ventilator settings are 18,450, which is about 6 cc's per kg of ideal body weight. 40% and 8. Their ID ratio is still 1 to 3. Their most recent peak pressures this morning were between 30 and 40. Plateau pressure was 28 and driving pressure was 14. They had an arterial blood gas from 3 hours ago. It was 7.34, 48, and 82. All right. We're getting more complex. I'm sure at some point we're going to have to edit out how we forgot some of the details around the patient. Let's go to step 5. This is oxygenation and ventilation goals, and this is not necessarily something you have to explicitly present because the team probably knows this, but depending on the clinical scenario, sometimes you do want to present this. You can briefly state targets. Sometimes you're doing things like permissive hypercapnia. Sometimes you're allowing some degree of kind of lower oxygen saturation. Sometimes you're doing different lung protective strategies. So if you're going to present the goals, it's easy to do it after the arterial blood gas. You could say things like achieving desired oxygenation with an SpO2 greater than 92%. And we are allowing for permissive hypercapnia in the setting of ARDS. Again, this is somewhat of an optional step. But it can be useful depending on the clinical scenario if you're not necessarily targeting the most standard endpoints. But we'll leave that out of our long presentation, and then we'll go to step 6, and then we'll do 5 and 6 together. So step 6 is the most recent chest x-ray. Many patients who are on ventilators get chest x-rays every day. You don't necessarily have to, but that's a discussion for another time. People have differing opinions on that. But if you are getting chest x-rays, it's really important to present the endotracheal tube location, how many centimeters above the carina it is, right? The carina is where that trachea bisects into the right and left bronchi. So that is important. Also, any kind of infiltrates, consolidations, atelectasis, certainly pneumothoraces are all important to present too. So you could say something like, most recent chest x-ray was from yesterday evening at 11 p.m. The endotracheal tube is 4 centimeters above the carina. There were bilateral infiltrates consistent with pulmonary edema. And then it's always really helpful to include a comparison to the previous. So you could say something like, this looks to be improving as compared to the x-ray from 2 days ago. So now let's see, we got step 1, which was mode. We have step 2, which was settings. We had step 3, which was pressures. Step 4, hopefully we're not making everybody not want to do critical care medicine. Step 4 was ABG. Step 5 was kind of targets for oxygenation and ventilation. Step 6 is chest x-ray findings. So let's see, if we were to do all this, you'd say patient X is on volume control. Their current ventilator settings are a respiratory rate of 18, tidal volume of 450, which is about 6 cc's per kg of ideal body weight, FiO2 40%, PEEP of 8. Their ID ratio is still 1 to 3. Their inspiratory pressures or peak pressures this morning range from 30 to 40. Their last plateau pressure was 28 with a driving pressure of 14. They had an arterial blood gas from 2 hours ago. It demonstrated pH 7.34, PaCO2 of 48, PaO2 of 70. They are currently achieving their targets for ventilation and setting a permissive hypercapnia as well as oxygenation. Most recent chest x-ray was from 24 hours ago. The endotracheal tube was 3 centimeters above the carina. It did demonstrate improving bilateral infiltrates that we thought was pulmonary edema as compared to the chest x-ray done preceding that. All right. Hopefully we didn't miss any parts of that when we were saying it out loud. We didn't prep these ahead of time, so we're doing them in real time. And last but not least is the clinical assessments and plan. This is where you go from just reciting the information to actually interpreting it. This is the wrap-up interpretation. Now, sometimes this is best done in the plan. Okay, when you're presenting on ICU rounds, usually you present the data first, and then you go into a plan. So our practice pattern is to put all this in the plan, and if you're going to do that, just say, once you're done talking about the ventilator, we'll talk about adjustments, and if you're doing a head-to-toe presentation, so you can talk about adjustments in respiratory or in pulmonary, but just speak that out for everybody so that they're not anticipating you're going to talk about the plan there. If someone wanted to talk about the plan there, in our mind, it'd be a little bit out of order, but certainly you could. But the things you're kind of thinking about are every day for every patient, are they ready for a spontaneous breathing trial? This is absolutely critical. You should explicitly say yes or no, and if the answer is yes, they should get a spontaneously breathing trial. Obviously, are they improving or worsening? Do you need to adjust any of their ventilator settings? Any signs of patient ventilator desynchrony is important to think about too, okay? So this might look like in your plan, you already went through the whole ventilator and you say something like, patient has had improving oxygenation. They're currently on an FiO2 40% of PEEP of 5. They're ready for a spontaneous breathing trial, which we will do this morning. Or this could be the patient has had worsening hypoxemia in the setting of interval chest x-ray that showed a new pulmonary infiltrate. They are not ready for spontaneous breathing trial as their FiO2 is up to 80%. We're going to increase their PEEP from 8 to 10 to assist in oxygenation, and they are having a lot of ventilator desynchrony secondary to their tachypnea. We're going to, do XYZ depending on what the desynchrony is. So if we are going to connect steps 1, which was mode, step 2, which was settings, step 3, which was pressures, step 4, which was ABG, step 5, which was are we hitting our goals, step 6, which was chest x-ray, and step 7, which was clinical assessment, which is usually in the plan. We would say something like, patient X is on, and we're not going to use the abbreviations, we're just going to use the order of things. So patient X is on ACVC
18, 450, 40%, and 8 with an I to E of 1 to 3. Peak pressures are 30 to 40, plateau of 28 with a driving pressure of 14. Most recent ABG from 1 hour ago, 7.34, 48, and 68. We are achieving our goals of SpO2 greater than 90%. Most recent chest x-ray was from 3 hours ago. Endotracheal tube was 3 centimeters above the carina. There was improving bilateral infiltrates as compared to the chest x-ray yesterday. And then forwarding to plan, patient has had improvement in oxygenation. They're ready for a spontaneous breathing trial, which we'll do this morning. They're comfortable without any ventilator desynchrony. All right. Hopefully that wasn't too much, but it is a lot. But this is next level presenting on rounds. This is, would be absolutely fantastic. If we were to go down, I think we wrote out an example too. We did. For the plan. This is something, if we were to kind of say the clinical assessment and plan, you could say something like the patient's oxygenating well on FO2 40% and PEEP of 8. Their plateau pressure remains less than 30. ABG shows mild hypercapnia, accepting in the setting of ARDS strategy with permissive hypercapnia, no acute changes on the chest x-ray. Plan to continue current settings and reassess readiness for SBT tomorrow. Another example of a plan. So quick tips for success. Always start with mode and settings. And really, this is all about repetition. Stick to a single structure and just do that every day for every patient over and over and over again. All right, use objective numbers, but then in the plan, interpret them clinically, right? So when you're presenting the numbers, just be objective. Don't use soft language like, their FiO2 is around 40-ish%. Really use objective. Their FiO2 is 40%. But then when you're interpreting them clinically, you can interpret them. But when you're objective, stay objective. And when you are interpreting, you can come up with a plan and instill some subjectivity to that plan. Tailor your focus in the plan for whatever you're treating. Is it ARDS? Is it COPD? And be ready to talk about the settings they're on, suggest weaning escalation, and always talk about, are they ready for their spontaneous breathing trial? Anyone on a ventilator, the goal is always to liberate them from that ventilator.
All right, everybody, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's topic is one that we're kind of rolling back. We realize we've been doing a lot of more, intermediate to advanced mechanical ventilation topics. Most recently, we talked about mechanical power, which is certainly an advanced topic, but we wanted to make sure we also were covering the foundations, the things you need to start to build your understanding of mechanical ventilation. And that's what we're going to talk about today. This is going to be a shorter episode, and we're going to get right to the point and talk about mechanical ventilation core settings: PEEP, FiO2, a respiratory rate, tidal volume, and inspiratory pressure. And this will get into volume control and pressure control just a little bit. But we're going to talk about what each of these variables and settings are, why they're important, when to titrate them, where to start with them, and all that good stuff. So by the end of this episode, you should at least have a good foundational grasp on the most important portions of mechanical ventilation settings, which would be these 5 variables. So no further ado, let's dive in. Starting with the fraction of inspired oxygen. What is it? Well, the fraction of inspired oxygen, also known as the FiO2, is literally the percent of oxygen being delivered to the patient. So every time a breath is given, this is the percent of that air that is oxygen. And the range here is going to be starting at 21%, because at sea level, right, 21% of the air we are breathing is oxygen. As I stand here right now, 21% of the air I am just taking in of room air is oxygen. So we don't tend to go lower than 21%, but you can go 21% all the way up to obviously 100% FiO2. This is the maximum. This means all the air being delivered on the ventilator is all oxygen, right? 100% of it. So you can't go higher than 100%. Now, sometimes when we're titrating ventilators, people are hesitant on the FiO2 to go, lower than 40% or lower than 30%, right? Oftentimes we'll hear that 40% is minimal or 30% is minimal. Just know that, this is somewhat just arbitrary and made up. You certainly can go down to 21%. This is all just intended to be educational and opinion. None of this is intended to be acted upon as medical advice. Our practice pattern, though, tends to be that we'll go as low as 30%. Every once in a while, for a patient that's got a prolonged ventilatory course, we'll take it down to 21%, but we usually stop at 30%. That's just a practice pattern thing. Too much oxygen, hyperoxia, superoxia is injurious, right? You get free oxide radicals and all these things that can cause local injury to the lung. You can get something called reabsorption atelectasis as well. So too much oxygen is certainly bad. So you want to titrate that FiO2 down as you're able. But just know that this 40% or 30% is arbitrary, but 21% is the real lower value you can do, because that is the oxygen percent at room air. And we should say, actually, while we have you, that if you want this study guide, this PDF, what we're literally going through today, this exact document, you can download it on our Patreon page. We have a wonderful Patreon community on all things emergency critical care medicine. Gosh, it's probably one of the largest collections of emergency critical care educational material out there. We got full emergency and ICU curriculums, ad-free videos, every single study guide for all the videos, practice questions, mini courses, medical education posts. Gosh, numbering in the hundreds at this point. So we've been putting a lot of time into it. We're very excited about it. We've had a lot of great feedback and a lot of people joining it. We'd love for you to check it out. So if you're interested, or if you want to download the PDF for this episode, print it out, download it, annotate it, whatever you want, check out our Patreon page. It's linked in the episode description, as well as the pinned comment on YouTube. All right, sorry about that. We just want to make sure you have that tidbit of information while we're going through all this. So what does the FiO2 do? We've talked about this a little bit, but this directly increases the alveolar oxygen concentration. And if we're going to break down what that means, our lung is composed of just, upteen thousands of alveoli. These are these little kind of balloons, and they have blood vessels on the outside of them. They're very thin walled, and air travels in them, expands the alveoli or alveolus, and then that oxygen diffuses into the bloodstream. Carbon dioxide, let's just get a different color. Carbon dioxide diffuses out of the bloodstream into the alveoli. Then when the breath is done, the alveolus contracts. That carbon dioxide is pumped out of the alveolus, and it travels, into bigger and bigger airways, eventually into the bronchi, trachea, and then out of the mouth. And that's how you expel carbon dioxide. So increasing the FiO2 is just going to directly increase the alveolar oxygen concentration. The higher the FiO2, the higher percent of oxygen in this alveoli, so that your bloodstream can absorb higher concentrations of oxygen. And this improves oxygenation. And that's a concept that we're going to come back to. We're going to be talking about some of these settings in terms of oxygenation. And then the other variable we'll be talking about is ventilation. Oxygenation is literally the oxygen saturation. So increasing FiO2 increases oxygenation. Ventilation is how well we're clearing carbon dioxide. Increasing FiO2 doesn't directly change ventilation, although there is some complex physics that can occur that can help with CO2 removal, but that's probably, since we're trying to keep this as kind of a foundational discussion, not part of the discussion currently. So FiO2 increases oxygenation. It doesn't do anything for ventilation or carbon dioxide removal. So how to set the FiO2? Well, most commonly, when you first put a patient on mechanical ventilation, you'll just put it at 100% because you don't know how the patient's oxygenation is going to change after you perform endotracheal intubation. But what you really want to do is you want to make sure you rapidly titrate it down because you want to avoid oxygen toxicity like we talked about. And oxygen toxicity is both local free oxide radicals that can cause damage, as well as you can get something called reabsorption atelectasis, which is where parts of the lung actually get atelectatic when there's too high of a percent of oxygen. Typical target, is 88 to 96%, somewhat disease dependent. The key here is you want to avoid both less than 88% and more than 96%. Hypoxemia and hyperoxia, both are injurious to the lungs and the body. So key concept here, FiO2 is a temporary fix for oxygenation. One thing to note that we'll get into is, most people say, although it's not necessarily robustly evidence-based, but most people say that if your ventilator has a setting of an FiO2 more than 60%, that is when you start to get some of those things like local free oxide radicals and reabsorption atelectasis. So if your FiO2 is more than 60%, you should really think about increasing your PEEP. All right, and we'll get into that more in the next section, which is PEEP. PEEP stands for positive end expiratory pressure. Now let's think about what that means. Positive end expiratory pressure. What that is, it is the pressure in the ventilator that it is giving, and that's already doesn't make sense. It is the pressure that the lungs are experiencing at all times. And the reason it's named this is because when you get a breath, right, here's your trachea. If you're listening to this in podcast version, don't worry, you're not missing too much. We're just doing a bad drawing of a trachea and lungs. When you get a breath, right, it pushes air in, trachea, bronchi, into smaller bronchioles, and it inflates the lungs. And that creates an amount of inspiratory pressure. But when that breath is done, those lungs deflate and that air travels back out of the trachea. At the end of expiration, there's obviously no inspiratory pressure. So the PEEP is the pressure at the end of expiration, the positive end expiratory pressure. And this is a setting on the ventilator. You know, ventilators have it all different, but usually there's a screen. Screen maybe in the top right corner has the peak pressures. There's usually some variables on the left side. This is obviously brand dependent. And then on the bottom, there's usually a couple settings, you know, FiO2, which we talked about, respiratory rate, which we will talk about, PEEP, which we talked about, and tidal volume, which we will talk about. If it's a pressure control mode, this is going to be inspiratory pressure instead of tidal volume. But we talked about FiO2 and we're talking about PEEP now. So you set the PEEP. The PEEP is a number that you set on the ventilator, which is the amount of pressure that those lungs are experiencing at all times. Even at the end of expiration, they're still experiencing that pressure. And why we do that is it prevents alveolar collapse. Remember that drawing we did above where you have all these alveoli, right? Up to thousands of them. And they're very thin walled. And if there's no end expiratory pressure exerting some force on these thin walls, they'll collapse down. And this is atelectasis, right? If you have this shrivel, collapse down alveoli, that's how you get atelectatic. So positive end expiratory pressure continues to exert a small amount of expiratory force on these thin-walled alveoli to keep them open, keep them recruited, is a word we often say, and prevent them from all collapsing and causing atelectasis. So what does it do from an oxygenation ventilation standpoint? Well, remember we said oxygenation is literally the amount of oxygen in the blood, right? The oxygen saturation is a manifestation of that. And that's compared to ventilation, which is the amount of carbon dioxide. So oxygenation controls oxygen in the blood, ventilation controls carbon dioxide. PEEP improves oxygenation. And it does this by keeping alveoli recruited so that they can exchange air, right? Because if our alveoli are all collapsed down, those blood vessels that are supposed to be absorbing the oxygen, they're not going to be exposed to oxygen because the alveoli is all collapsed down. So when you're trying to breathe air in, it can't even get to the alveoli because the alveoli is collapsed and atelectatic. So none of the air can actually get to the blood vessel to get absorbed. Whereas if you have that PEEP and you have this nice and recruited and open, all that air you're breathing in can get into the alveoli and then get reabsorbed into the bloodstream, right? So it recruits collapsed alveoli and improves VQ matching. This gets into a concept called functional residual capacity. It does increase that. I think we're probably just going to bypass that because that's going to be a whole rabbit hole that probably is a little more on the intermediate side of complexity. So how to set the PEEP, just like we talked about the FiO2. So we said the FiO2, you usually start at 100% and then you wean down as fast as you can. The PEEP for just the run-of-the-mill person, starting it at 5 is not unreasonable. 5 is what we kind of consider, quote-unquote, minimal PEEP. But this is very pathology dependent, okay? If you have lungs that have pulmonary edema or pneumonia or diffuse alveolar hemorrhage or anything else, you know, blood, pus, water, all of that usually requires a little bit higher PEEP because those pathologies lead to more alveolar collapse. So you need more PEEP to keep those alveoli recruited. Whereas if you have someone who is intubated just because they had a huge stroke and they're confused, but their lungs are okay, then 5 of PEEP's plenty. We don't usually go less than 5 of PEEP. There's some unique scenarios where some people talk about ZEEP or 0 PEEP, but we don't tend to believe in those necessarily, and our minimum is 5 of PEEP. But if we have a patient who's got really bad pulmonary edema or pneumonia or diffuse alveolar hemorrhage and they need to be intubated for refractory hypoxemia, we might start their PEEP at something like 10 rather than 5. But again, this is a matter of weaning down. Now, key trade-offs here, right? The benefits in oxygenation from PEEP is totally dependent on how distended the alveoli are. So if we draw 3 alveoli and you have one that's collapsed down, you have one that's perfectly distended, and then you have one that is what we call over distended, the patient that's going to benefit from more PEEP is going to be the one that is under distended or collapsed, because if I increase the PEEP, that will make this more collapsed alveolus more optimally distended, which is going to improve our oxygenation. But if we are already optimally distended or we're over distended, increasing the PEEP is actually going to worsen oxygenation, because it's just going to cause worsening over distension, and that's going to damage the alveoli, and they're not going to be able to absorb oxygen efficiently. So increasing PEEP does not magically just increase oxygenation. It only increases oxygenation if there is recruitable lung units available, aka there's portions of the lung that are under distended or collapsed that you could recruit by increasing PEEP. All right. The other thing to note here is FiO2 improves oxygenation quickly, because you're literally just increasing the amount of oxygen being delivered to the alveoli. PEEP, though, takes time. All right. It is not often an immediate magical fix. It also takes time to see what happens if you're going to decrease the PEEP. So when you're making ventilator changes, FiO2, you'll see the effects quickly, usually in a matter of minutes. PEEP often takes hours to see the effects, at least the full effects. So FiO2 titrations, you can do quicker. PEEP titrations, you certainly should do low and slow, right? Don't overdo it, because if you overdo it, you'll either lead to over distension, but it'll take an hour or two to realize it, and then you'll be way behind, or under distension, and the same thing, an hour or two to realize it, and then you'll be way behind. All right, what about tidal volume? So on our vent settings, we, talked about FiO2, we talked about PEEP. Now we're talking about tidal volume. And just know that tidal volume is only a setting that we change and set in volume control mode. And on our channel, we've talked about volume control and pressure control and tons of mechanical ventilation stuff. So if you want to look that up, just search Whiteboard Medicine volume control, and we'll have a ton on it. But just know, if you are on a pressure control mode of ventilation, you're not setting the tidal volume. So if you're on volume control, that is when you'll set the tidal volume. And the tidal volume is literally the amount of air being delivered with each breath, right? Do you want 300 cc's of air? Do you want 500 cc's of air? It is quite literally the volume of air being delivered with each breath. And what it does is it helps with what we call minute ventilation, right? You're starting to see ventilation now, just like FiO2 was oxygenation and PEEP was oxygenation. Tidal volume is ventilation. And we talked about that ventilation is what clears carbon dioxide. So tidal volume is part of minute ventilation, and we've talked about minute ventilation on the channel before as well, but minute ventilation equals respiratory rate times tidal volume. This is literally the cc's of air that the lung is getting delivered every minute, right? Because it's the tidal volume, which is the amount of air delivered with each breath, times the respiratory rate, which is the amount of breaths per minute. So it makes sense that that is the minute ventilation. And this helps with CO2 clearance, right? Because you're going to have more minute ventilation, that the CO2 is going to be able to diffuse into the alveoli, and then you could breathe that out. So how do we determine the most appropriate tidal volume? Well, usually we start with something called predicted body weight. Sometimes we actually call it ideal body weight. And this is just based on a patient's height, because everyone's thoracic cavity is about the same size depending on your height, no matter how much you weigh. So someone who is 5 foot 10 inches and weighs 100 pounds, their lungs are similar in size to someone who's 5 foot 10 inches and weighs 400 pounds. So we don't want to use the 400 pounds to calculate things, because their lungs are the same size as the 100 pounds. So we use the ideal body weight based on the actual height of the patient rather than the weight. And you could just look this up. We don't get any money from MD Calc or anything like that, but we usually just type in MD Calc ideal body weight, and you could just put in the patient's height, and it'll kick out their ideal body weight number. And typically what we shoot for is about 6 to 8 cc's per kg of ideal body weight. And the reason we do this is because there's been some trials in lung protective strategies where going above that can sometimes be injurious to the lungs and lead to ventilator-induced or associated lung injury, right? Because the amount of air you're pushing in is going to inflate those alveoli. So if you have too much air being pushed in, it's going to over distend those alveoli and cause trauma. All right, so 6 to 8 cc's per kg of ideal body weight is a nice start. So if someone's ideal body weight is 50 kilograms, a nice start is something like 400 cc's of tidal volume would be 8, and then 300 cc's of tidal volume would be 6 cc's per kg, right? So someone's 50 kilos, 3 to 400. Someone who's a more kind of regular size is about 70 kilograms. So you could see 6 times that would be 420 cc's of tidal volume per breath. A lot of times you'll see respiratory therapy, if you have them, will just kind of set the tidal volume at about 450, which works for most people unless they're on the higher low end of the height spectrum, like less than 5 feet or greater than 6 feet. Key concept here, larger tidal volumes is better CO2 clearance, but larger tidal volumes can be injurious to the lungs, so stick to that 6 to 8 cc's per kg. Smaller tidal volumes can be longer protective, but it can cause increased CO2. Now, we often will allow for something that we call permissive hypercapnia, but that is a little outside of the purview of this episode. Again, we've talked about it a whole bunch of times, so just look up whiteboard medicine permissive hypercapnia and it'll come up. All right, let's see what we got. 2 left. Next is the respiratory rate, right? So again, here's our ventilator. Here's the settings that we set. And we talked about the FiO2, which helps with oxygenation. We talked about the PEEP, which primarily helps with oxygenation. We talked about the tidal volume, which helps with CO2. Now we're on the respiratory rate, which is also going to help with ventilation or CO2. We talked about FiO2. We usually set it 100%, but wean down as quick as you can. And the changes to FiO2 are seen pretty quickly. We talked about PEEP, which usually we start somewhere between 5 to 10, but it's pathology dependent, and know that changes are seen more slowly, so don't make changes quickly. We talked about the tidal volume, which we do 6 to 8 cc's per kg of predicted or ideal body weight. And now the respiratory rates. The respiratory rate, as one might think, is the number of breaths delivered per minute. Okay, what it does is it also controls minute ventilation, right? We talked about tidal volume and minute ventilation. Well, respiratory rate is that other variable, and this is the main determiner of CO2 elimination. Typical starting respiratory rate is physiologic, right? We breathe about 16 times per minute, so most people set the respiratory rate 16 to 20. Now, do note that this is also pathology dependent. If you have someone who's acidemic, metabolic acidemia, who's breathing 30 times per minute, and you have to intubate them, which goodness forbid, because that's a patient that intubating them and taking away the respiratory drive might be deadly. But let's say you have to, you don't want to start them on a respiratory rate of 12. They'll die, right? Because when you intubate someone, you're taking over their ability to compensate for metabolic acidosis. So if they're, acidemic from a metabolic standpoint, you might be starting that respiratory rate at something like 28. Right? The catch to this, though, is patients can only tolerate so much respiratory rate on mechanical ventilation. At some point, they'll start doing something called auto PEEP. And auto PEEP can actually worsen CO2 levels and can kill patients. And not to be a broken record, but we got episodes out on auto PEEP too. Just search whiteboard medicine auto PEEP and it'll pop up. All right, so higher respiratory rate, you'll clear more CO2 usually, but you will risk air trapping and auto PEEP. Lower respiratory rate, you can risk hypercapnia or worsening acidemia because you are not compensating for metabolic acidosis if they have one. So CO2 high, think about increasing respiratory rate first rather than tidal volume because that's more lung protective probably, but be very cautious of auto PEEP. All right, last but not least is the inspiratory pressure. And we put this on here because when we draw our ventilator settings, right, we said FiO2 is one that we can pick and set, PEEP is one we could pick and set, tidal volume is one we could pick and set, and then respiratory rate. But tidal volume here, like we said, is only a variable that you pick and set when they are on a volume control mode of ventilation. The other mode we commonly use is pressure control, right? And in pressure control, you still set the FiO2, you still set the PEEP, you still set the respiratory rate, but instead of the tidal volume, you're going to set an inspiratory pressure because it is pressure controlled. And this inspiratory pressure then develops a tidal volume, but you're not controlling the tidal volume, you're controlling the inspiratory pressure. So just for an example, right, let's say you set the inspiratory pressure at 10, that means the ventilator is going to give a pressure of 10 millimeters of mercury with each breath. And whatever those lungs take for their tidal volume is what they take based on their compliance and all that kind of stuff. So maybe an inspiratory pressure at 10 creates 200 cc's of tidal volume. But this number might vary, right? If they get sicker, maybe
In an hour, it's 150 cc's, or maybe they get better, and in an hour, it creates 250 cc's of tidal volume. If you want more tidal volume, you have to increase the inspiratory pressure, right? Let's say you increase it to 20. That might then lead to 400 cc's of tidal volume with each breath. So the tidal volume becomes the uncontrolled variable, and the inspiratory pressure is what you're controlling. And this is only in pressure control modes. So inspiratory pressure is the pressure applied during inspiration, which determines how much air flows into the lungs. It controls the tidal volume indirectly based on lung compliance and airway resistance. To set it, we usually use the developed tidal volume to set it, right? So if we want the tidal volume to be 6 to 8 cc's per kg, we will pick an inspiratory pressure. We'll look to see what the tidal volume is, and then we will increase or decrease the inspiratory pressure to try to get to the adequate tidal volume. But we are always watching what this inspiratory pressure value is, because we don't really want it to go above 30, right? Because that can start to be injurious to the lungs as well. All right, so you could choose whatever, inspiratory pressure 10 or 15. Make sure you don't go above 30, and then titrate it to achieve the tidal volume you want. But just know that might change breath to breath, hour to hour, right? The tidal volume might be higher or lower, just depending on how the patient is doing. So the pressure is what you set, and the volume is the variable that's uncontrolled. So when you want to limit airway pressures, this can sometimes be helpful because the airway pressure maximum is what you're actually setting, is the inspiratory pressure. Whereas if you're setting the tidal volume in a volume control mode, the peak pressure, the pressure that is being developed, is the uncontrolled variable, okay? Whereas when you're setting an inspiratory pressure, that's the controlled variable, and the tidal volume becomes uncontrolled. Again, this is a little complex, but just check out our episodes, pressure control and volume control, and it all makes sense. So putting this all together, when we think about oxygenation versus ventilation, if we need to improve oxygenation, FiO2 is the quick fix, and PEEP can be the fix depending on if there's alveoli to be recruited. To fix the carbon dioxide levels, respiratory rate's the first fix. Tidal volume can be something to consider too. Always monitor for auto PEEP. Quick bedside approach, low oxygen, increase the FiO2 first to buy you time, and then consider increasing the PEEP as the clinical circumstances allow. High carbon dioxide, increase the respiratory rate first, assuming there is no auto PEEP. And if you're unable to achieve your goal with the respiratory rate, consider the tidal volume, but only with caution, because this can actually really cause harm, okay? So part of us wants to just take that out, but it's not unreasonable depending on the clinical circumstances. Key takeaways to wrap it up: FiO2 and PEEP are what drive oxygenation. Respiratory rate and tidal volume drive ventilation. Inspiratory pressure controls the tidal volume and pressure control modes, and always prioritize lung protection. All right, welcome back, everybody, to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's topic is one that's really foundational for a lot of what we do in emergency critical care medicine with our critically ill patients, and that is the venous versus arterial blood gas difference. So we're going to be comparing blood gases from the venous system versus the arterial system. We'll talk about what they're best used for, what you can kind of get away with, what you should be thoughtful around when you are using a blood gas for one indication or another. We'll also talk about what values are derived, calculated versus directly measured, all that good stuff. So these are tests that we send on patients pretty much every single day in the clinical arena, and having a good grasp on what is accurate and what might be inaccurate in which clinical circumstances can be incredibly important. So no further ado, let's dive in. We did just want to let you all know, as always, that if you want this study guide, this PDF that we are actually going through, you can download this off our Patreon page. We have all of the PDFs and study guides from every episode on there, and there are a ton of other stuff too. It's probably one of the biggest collections of emergency critical care educational content out there. Full ICU curriculums, study guides, practice question banks, mini courses, clinical reviews, medical education posts, all that kind of stuff. We've been super excited about how much it has grown, and we've been spending a ton of time trying to make sure that that community and the content on that community is up to snuff and helpful for folks. So we'd love for you to check it out if you just want to be a fellow emergency critical care nerd like us and join some like-minded folks. That's another awesome area to do it. So linked in the episode description as well as the pinned comment on YouTube. No further ado though, let's get back to ABGs versus VBGs. So let's start with why this matters. Well, when we're doing a blood gas, we're not just interpreting numbers, right? We're thinking about how those numbers are generated, right? Are they measured? are they calculated? If they're calculated, what are they calculated from or on what? Because that will help you understand what you can kind of quote unquote trust in that blood gas and what you might misinterpret. Because if you misinterpret something and then apply it to that patient's clinical scenario, you run the risk of going down a tricky pathway. So the core concept here, an ABG is an arterial blood gas. This is sampled from the arterial system. Often it's a radial artery that you do a radial artery stick on. You can do it in the femoral artery, not suggesting you should or shouldn't, but most commonly it is from the radial artery. But it's an arterial blood gas sample, so the blood is taken from the arterial system. This is the gold standard when we're talking about oxygenation, right? We're going to get into all this in a lot more detail, but if you're looking at the PaO2, the amount of oxygen dissolved in the arterial system, an ABG is what you need to do that. It also gives you a more precise view on gas exchange, right? Things like pH and even PaCO2 are all going to be quote unquote more accurate on an ABG. A VBG, on the other hand, is taken from the venous blood, right? You can take this from any vein if you have an IV that draws back, things like that. So this is venous blood. And this venous blood will not give you as accurate of a view on things. It is completely inaccurate for some things like the PaO2. It can give you a fairly reliable surrogate for things like acid-base, pH, and ventilation, PCO2. But there's some caveats here, and we'll go through what those caveats are. So both rely, when we're sending an ABG or VBG, there's a number of things that it will tell us, right? When we're thinking about these blood gases, the things that the blood gas are going to tell us are going to be pH, PCO2. This will all be on there, whether it's accurate or not. PO2, bicarbonate, and there's some other things that can pop up in there too, but these are the big four that we often send the blood gas for. And some of these are calculated, some of these are directly measured, some of these are accurate on a venous blood gas, some of them are only accurate on arterial blood gas, and that's what we'll get into as the episode progresses here. So let's start with what's actually measured versus what is calculated. Remember, measured is going to have less variables affecting it. So these can sometimes be more trustworthy, the things that you're directly measuring, assuming the measurements are happening in a accurate way. Calculated, though, these are just derived from different variables. So if the variables they're derived from are incorrect, the calculated measure will be incorrect. So directly measured on blood gases are going to be the pH. Okay, this is directly measured in a gas electrode. The PCO2, this is directly measured on an electrode as well, and the PO2, this is directly measured on the Clark electrode. So these are all kind of true primary data. Now, with that being said, that doesn't mean let's rephrase that. This means that the numbers, assuming they're being measured accurately, are accurate numbers, but you have to be thoughtful about what they're measuring, right? So if you get a venous blood gas, a VBG, the PCO2 is technically a PVCO2, right? A partial pressure dissolved oxygen in the venous system. Same thing with the PO2, there's technically a PVO2, or the partial pressure dissolved oxygen in the venous system. So this is not to be mistaken with a PaO2, which is the partial pressure dissolved in the arterial system. So don't mistake directly measured and kind of true primary data as accurate in terms of it showing what you hope it shows, but it is accurate in the sense that it is a directly measured variable within the type of blood gas you send, right? So the pH, the PCO2, and the PO2 are all directly measured. They're quote-unquote accurate, assuming they're being measured appropriately, but they represent either the venous values or the arterial values, which can tell you different things, which we'll talk more about. The calculated values are interesting, and this is something that folks don't always realize, but these calculated values are derived mathematically. So essentially they take math equations and the measured values and then calculate or derive these values. And the things that are derived are the bicarbonate, the base access, and the oxygen saturation. Sometimes this is directly measured, but most of the time the oxygen saturation is calculated as well. But the big one that people don't think about is the bicarbonate. This is actually a calculated value. And to calculate it, they use this equation. So they use an equation, bicarbonate equals 0.03 times the PCO2 times 10 to the pH minus 6.1 power. So you already see here, the fact it's calculated means that the PCO2 has to be accurate, the pH has to be accurate, these assumed kind of coefficients coefficients of 0.03 and 6.1 have to be accurate. So all this kind of limits, maybe limits isn't the right word, but you should be thoughtful on whether this is an accurate value, because it's going to be based off of these measured values as well as certain other coefficients and variables, which then just introduce a degree of error that wouldn't be present if you were directly measuring it. So the bicarbonate on the blood gas, in our humble opinion, you can use it, you can think about it, but the bicarbonate on a basic metabolic panel is going to be much more accurate because it's directly measured, whereas the bicarbonate on a blood gas is a calculated value derived from this long equation that uses both coefficients as well as directly measured values like PCO2 and pH. All right, so that was just a quick glimpse into what's measured and what's calculated. So measured is pH, PCO2, PO2. Calculated is bicarbonate base access and O2 saturation. So translation, if the pH or PCO2 is off, the bicarbonate is also going to be off because it's calculated using the pH and PCO2. So it's not independently measured. Well, let's get into the bulk of this video, which is going to be the ABG versus VBG, a comparison. This table here, and if you're listening to this in podcast version, we do have a table. We'll go through the table, but if you want to actually see it, we obviously link the video in the podcast description, so you could hop over to YouTube if you want. Or if you go to our Patreon page and want to download this study guide, obviously it'll be printed out there and you can annotate it as you see fit. So just to understand the table, we have columns of parameter, ABG, VBG, Y, and clinical takeaway. And then our variables are pH, PCO2, PO2, bicarbonate, and O2 saturation. The thing to note here is the verbiage we're using in the table is often higher or lower. And ABG and VBG, the verbiage is comparing it to the other. So, for instance, this first line here, ABG is higher. That means that the ABG value is going to be higher than the VBG value. And then VBG is lower, which makes sense. So these are obviously opposite each other. There's no kind of like gold standard that we're comparing both of these two. We're comparing the ABG to the VBG when we use verbiage of higher and lower. So the first parameter is the pH. And the pH on an ABG is going to be higher than the VBG, and we often consider the ABG pH kind of the more accurate one. So ABG pH is the more accurate one, and that stands true for a lot of these values. The VBG pH is often 0.03 lower than the pH on the ABG. And the reason for this is because carbon dioxide accumulates in tissues, and as CO2 goes up, our pH goes down. So when we do a venous blood stick to get a VBG, a venous blood gas, we are pulling that venous blood from the tissues. We're pulling that venous blood from the blood that has already traveled through the tissues. So if you think about the heart pumping blood, goes into the arterial system, into arterioles, into capillaries. And that blood delivers oxygen as well as other things, but then it also reabsorbs CO2 from those tissues. That then goes into a venule, into a vein, and back to the heart. So the blood in that vein has already accumulated CO2 from the tissues, and that CO2 is going to decrease the pH a little bit. So the VBG pH is often 0.03 lower than the ABG pH. And for most clinical scenarios, that's usable. It's kind of close enough. Now, do note, and we'll get into this more, that in critically ill patients, this is sometimes more inaccurate. So as patients get sicker, you have to be more careful with this. But in the run-of-the-mill patient, most people would say that a venous blood gas pH is about accurate. And certainly none of this is intended to be acted upon as medical advice. All this is just for educational purposes. Please reference your institutional guidelines and societal guidelines to further understand this and make medical decisions. So just educational, but most people would say that this is pretty similar enough. So if you're just looking for pH and the patient is not critically ill, often a venous blood gas will suffice. What about the PCO2? Well, the PCO2, which is the amount of carbon dioxide dissolved in the blood, is often 4 to 6 higher in the venous blood. And if you were listening closely, the reason is the same as why the pH is a little bit lower, because carbon dioxide accumulates in the tissues, and that carbon dioxide from the tissues gets into the venous blood, so the CO2 is going to be slightly higher in the venous blood, and that's also why the pH is slightly lower, because higher CO2 drives down the pH. So CO2 in arterial blood gas is going to be a little bit lower than a venous blood gas, and the venous blood gas CO2 is going to be a little bit higher, 4 to 6. Okay. So again, this is a good correlation. Most people would say that you can use a venous blood gas to estimate what the CO2 is, and you don't need an arterial blood gas. But do note, again, as patients get sicker, this becomes less accurate, so you have to be more careful in those patients that are critically ill. Sometimes what we do is, if a patient's a hard arterial stick, we sometimes will get a venous blood gas, but we don't tend to make significant clinical decisions, such as let's intubate this patient for respiratory failure, without ensuring the arterial blood gas is similar to the venous blood gas that we got. All right, what about PO2? So we'll put PaO2 here, right? And this is the amount of dissolved oxygen in the arterial system. So this, hopefully, this little A written here, hopefully will show folks that the venous blood gas is not an accurate measure of the PaO2 because it's venous blood, not arterial blood. All that oxygen, not all, but a lot of that oxygen was extracted from the arterial blood before it got into the venous system. Oxygen's extracted by tissues, which makes the venous blood gas not an accurate measure for PaO2. You cannot use it. It's not functional in that sense at all. You need to get an arterial blood gas to determine the PaO2. So the first two, the pH and the PCO2, venous blood gases tend to be an okay surrogate, but the PaO2, you have to get an arterial blood gas. All right, so this is all ABG. You cannot get a VBG to estimate it. And then the other ones in this chart are the bicarbonate and the O2 sat. Remember, these are calculated values. So they're accurate only as so far as the math equation used to derive them are accurate. And remember, the bicarbonate is calculated using the CO2 and the pH. So a venous bicarbonate, uses the venous CO2 and venous pH. We already said the venous pH is often 0.03 lower than the arterial pH, and the venous PCO2 is often 4 to 6 higher than the arterial CO2. So the bicarbonate calculated on the venous blood sample is, accurate-ish, but again, as you're getting further down this road, or patients are getting sicker, these calculated values are sometimes not super useful. Okay, and oxygen saturation, same. Now, sometimes co-ox can directly measure it, but venous saturations are not accurate. An ABG saturation does tend to be accurate, so you cannot use a VBG to get an O2 sat on your blood gas. You need an arterial blood gas to do that, or just look at the pulse ox. So in summary here, if we were to write this out, for a PaO2 or an SpO2, which on the blood gas is usually written SaO2, you need an arterial blood gas. For pH, PCO2, and then the calculated bicarbonate, you can usually do an ABG or VBG, with the very important caveat that the pH is going to be about 0.03 lower than the arterial blood gas. The PCO2 is going to be about 4 to 6 higher than the arterial blood gas. And as patients get critically ill, this becomes less accurate, so be very careful and get an arterial blood gas to confirm in the critically ill if there are significant arrangements you're worried about. So the physiology we're going to dive into a little bit more here. So venous versus arterial. Well, let's just draw a little kind of vascular bed here. So artery goes down into arterial, which goes into capillary, which goes into venule and vein, back to the heart. So if you're listening to this podcast form, we're just doing a really, terrible drawing because we're terrible at drawing, and it's probably not that helpful, but maybe it is. So this is going to be heart here, and then this is going to be heart here, right? Arterial blood pumps from the left side of the heart, and venous blood returns to the right side of the heart. And then this is capillary. Okay, this is arterial. This is venule, vein. Blood travels in this direction, left side of the heart, into artery, arterial, capillary, venule, vein, right side of the heart. And you have all these kind of muscle beds here, all these tissues, and that's what these capillary beds are perfusing, right? So oxygen and nutrients from the blood go out into the tissues. Carbon dioxide and waste from the tissues goes back into the capillary. So that means there's more CO2 in this venous blood because it reabsorbed from that capillary bed, and there's going to be much, much less oxygen in this venous blood because all that oxygen was delivered to the tissues compared to the arterial. So the tissues consume oxygen, produce carbon dioxide, generate acids. So the venous blood reflects what's left after metabolism, which is why, as we said, the CO2 is going to be higher in the venous blood. The pH is going to be lower in the venous blood. The arterial blood reflects what's being delivered. And that's why this is going to be accurate oxygen in the venous blood, whereas in the in the arterial blood, that was a bad misspeak. Let's just say it again. In the arterial blood, the oxygen levels are going to be accurate, so your PaO2 is going to be accurate. In the venous blood, you can't even use the venous blood to get a PO2. It will not be reflective of your PaO2. Now you can get there's other uses for oxygen saturations in the venous blood outside of the scope of this episode, but there's something called a central venous gas, and SVO2, which is oxygen saturation of the venous blood returning actually to the heart and lungs. But again, for this episode, we won't dive into that. So just note, venous blood fairly good for pH and PCO2, not accurate for PO2 or SaO2. For the physiologic reasons we talked about. So when is VBG enough? Just to knock it home, it's enough for pH often, PCO2 often, and bicarbonate, which is calculated, with the caveats being pH is going to be about 0.03 lower, PCO2 is going to be about 4 to 6 higher, and then the bicarbonate is calculated off these values, so you will get a little bit of inaccuracy, with the second caveat that critical illness makes this even less accurate, so just be thoughtful of that and careful. ABG is required if you need a PO2 measurement or an accurate oxygen saturation on the gas, or if you're worried that the VBG is not accurate based on critical illness. So high yield pitfalls, quote unquote, normal bicarbonate can be misleading because it's calculated from the pH and PCO2. So if those are wrong, your bicarbonate is wrong. Pulse ox versus ABG saturation mismatch. ABG calculates the saturation. Pulse ox measures the light absorption. So there's shortcomings to each of these. For instance, carbon monoxide, CO poisoning. The ABG may look normal, but the patient is hypoxic, right? So there's some, if you have an interest in the clinical conditions that cause a difference between the ABG oxygen saturation and the pulse oximeter oxygen saturation, let us know. That's probably an interesting episode. So if you're interested in that, let us know. We won't belabor it here because it's probably a whole episode in and of itself. And then VBG reliability depends on perfusion, and that's why critical illness can throw this off. Poor perfusion is going to lead to altered venous sampling and less predictable relationships between the venous blood and arterial blood. Poor perfusion, right? There's patients in shock. There's patients who with critical illness. So again, these rules I think are reasonable, but you will see a significant discordance between arterial and venous blood in the critically ill at times. So don't put all your marbles in the bag of the venous blood sampling if it shows significant derangement. So quick mental model here, and we're getting close to the end. We do have some practice questions at the end, so stick around for that as a way to know if you took things with you or not. But measured values tend to be more true because there's less variables. Calculated values are an interpretation of that truth. Measured values are the PCO2, pH, PO2. All right, calculated values are the bicarbonate, okay, the base access, and the O2 sat. So always ask, am I interpreting a measurement or a calculation? Bottom line here, you're here, a high yield summary. We're going over the same points, but really just to try to take it home. Measured values are the pH, PCO2, and PO2. Calculated values are the bicarbonate, base access, and O2 sat. VBGs work fairly well for pH and PCO2. These are directly measured and they correlate fairly well, although do note in critical illness, this correlation may not be as close. ABGs required when you need oxygenation, the PaO2. All right, higher and lower, always venous versus arterial in the same patient if you're going to compare them. All right, let's get into some practice questions. We almost showed you the first answer. If you have not done practice questions with us before, there's 3 of them, and then the episode will be complete, usually beginner, intermediate, advanced. We'll read the question, read the answer options, and then we'll go right into the answer. So if you need more time to think about the answer, just pause the episode, okay? So question 1, which of the following variables is directly measured on a blood gas analyzer? A, bicarbonate, B, base access, C, PCO2, D, oxygen saturation. Pause if you need to. The correct answer is C, PCO2 is directly measured via electrode. Bicarbonate-based access and oxygen saturation are often calculated. Sometimes you can get an O2 sat if you're using colximeter that is directly measured. Okay, question 2, intermediate. A patient has a VBG showing a pH of 7.33, PCO2 of 50. Which of the following is the best interpretation? Severe hypercapnia requiring immediate intubation. B, likely mild hypercapnia with a reasonably accurate reflection of arterial carbon dioxide. C, uninterpretable. VBG cannot assess ventilation. Or D, indicates severe hypoxemia. Pause here if you need to. The correct answer is B, likely mild hypercapnia with a reasonably accurate reflection of arterial CO2. Right, so VBG, CO2, and pH is reasonably accurate. The CO2 is typically 4 to 6 higher than it is in the ABG. So in this question stem, the PCO2 is 50. So the real PCO2 in the ABG is probably somewhere around 45, which is just mildly higher than the normal. That's often written as 40. pH, right, is usually 0.03 lower. So this pH says 7.33, but in reality, it's probably somewhere around 7.36, which is normal, right? pH greater than 7.35 would be considered normal. So this correlates well in moderate ranges, and the VBG is reliable in most cases. Critical illness, though, can sometimes disrupt this. All right, last question. Which of the following scenarios would most likely result in the largest discrepancy between VBG and ABG values? A, stable deep KA patient. B, mild COPD exacerbation. C, septic shock with poor perfusion. D, anxiety-induced respiratory alkalosis. Pause if need to. The correct answer is C, septic shock with poor perfusion. So remember, poor perfusion makes the VBG less reliable because tissue extraction and perfusion are related. So in shock states, impaired perfusion and altered metabolism can lead to unreliable venous arterial correlation. So you got to be really careful using the VBG in these patients. And if you get a significant finding on the VBG, before you make any huge decisions, often clarify it is true with an ABG.
All right, everybody, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's topic is another request from one of our awesome Patreon members. Remember, Patreon members and YouTube members, you can certainly give us requests for content, and this is one of them, and it is stress ulcer prophylaxis in the intensive care unit. This topic is something that when you're in the intensive care unit, you'll come across on pretty much every patient every day. The question of, do you start stress ulcer prophylaxis? And there's a lot of protocolized approaches to this, and not all of them are evidence-based. You know, there's been new guidelines that come out in the last couple of years that kind of burst the bubble of, what many folks were doing, which was some degree of, if you're on mechanical ventilation, you get stress ulcer prophylaxis. If you're not on mechanical ventilation, you don't. The plot is much thicker, and that's what we're going to go over today. So hopefully by the end, you have a great evidence-based approach to those patients that might benefit most from stress ulcer prophylaxis. So stick around to the end because we go over a lot of that stuff. As always, none of this is intended to be acted upon as medical advice. This is all just for educational purposes, so please refer to your local guidelines when making clinical decisions. All right, no further ado, let's dive in. So the core concept here, what are we talking about? Well, stress ulcer prophylaxis is used in critically ill patients to prevent clinically important upper gastrointestinal bleeding. Many of you probably know this, but it's important to establish the foundation here. All right. So when you are critically ill, you can get stress-related mucosal injury, and we'll go over the pathophysiology of that a little bit. And the goal of starting stress ulcer prophylactic medications, things like PPIs, proton pump inhibitors, or H2 receptor blockers, is to prevent that stress-related mucosal injury from leading to clinically important upper gastrointestinal bleeding. Historically, stress ulcer prophylaxis, abbreviated SUP, for those watching the video portion of this episode, it historically has been broadly used in ICU patients, but some modern evidence and guidelines now suggest a more kind of selective risk-based approach, which is different than what we have classically done. So not all ICU patients require stress ulcer prophylaxis. It should be reserved for critically ill patients with meaningful bleeding risk factors. And this is the key kind of phrase here, meaningful bleeding risk factors. And it's something we're going to dive into a lot more. What are these meaningful bleeding risk factors? And when should we be thinking about using stress ulcer prophylaxis? As a friendly reminder for those listening and watching this, if your goal is to truly expand
your emergency critical care knowledge base and skill set, not just watch these videos. We've built a full structured curriculum for all emergency critical care topics on our Patreon page. As far as we're aware, it's probably one of the largest collections of emergency critical care educational content out there. There's close to 100 different study guides, mini courses, practice question banks, hundreds of medical education posts, clinical reviews where we cluster a bunch of the study guides together, those for renal replacement therapy, those for shock, those for mechanical ventilation, to make all that easily accessible, all on that Patreon page. So if you're interested and you're able, consider joining that today. It's linked in the video description, it's linked in the pinned comment, it's linked in the podcast description, all that good stuff. We're really proud of it. It's something that we've really been working hard on, and the community's been growing, and we're so grateful. So we'd love to see you there if you have an interest. All right, pathophysiology of stress ulcers. So what happens? Why do we get stress ulcers? Why are we even talking about stress ulcer prophylaxis? Well, when we are critically ill, when our body's under a significant amount of stress, we can get this stress-related mucosal injury. And this happens for a number of different reasons. Part of this is splanchnic hypoperfusion, right? Your guts, your intestines, your stomach are all perfused. Their blood flow comes from the splanchnic system. And when we are critically ill, there's some vasoconstriction in that system to try to shunt blood to the more important places, kidneys, brain, heart, and as such, you can get some hypoperfusion or kind of relative ischemia to your GI tract, and that can cause mucosal injury. Some of this is ischemia-reperfusion injury. If you cut off blood flow or decrease blood flow to an area for a period of time, and then you restore that blood flow, you get reperfusion injury. All those inflammatory mediators that kind of leaked out of the cells during the period of ischemia, then when you get that blood flow back, all get washed into the system and cause significant local inflammation and reperfusion injury. We see this, if you have an arterial occlusion in an arm or a leg, and then you restore that perfusion, you might get some ischemia-reperfusion injury, right? This is a concept that can be applied to more than just the GI tract. Inflammatory mediator release, right? When we're sick, we get inflammatory mediators. Some of that is local to the GI tract and can cause mucosal injury. And then impaired mucosal barrier protection. Your mucosal surfaces have a barrier, right? They're kind of exposed to the outside world. It seems funky, but the inside of our gastrointestinal tract is actually considered the outside world. And that mucosal barrier protects the rest of your body from that outside world. And when you get some impairment to that barrier from critical illness, again, that can contribute to mucosal injury. So these 4 different pathophysiologies can lead to stress-related mucosal injury, which then can lead to GI bleeding from ulceration of that GI mucosa. So these changes can produce these kind of diffuse superficial gastric erosions. That's most commonly in the stomach. And mucosal injury is common in critically ill patients, but clinically important bleeding is relatively uncommon. All right, so many critically ill patients get some degree of mucosal injury, but many fewer patients actually get bleeding from this mucosal injury. And this is why prophylaxis has become something that we think should be more targeted rather than just routine for everyone, because every drug has side effects. And proton pump inhibitors and H2 receptor blockers are medications that are, fairly well tolerated. A lot of folks take them in the outpatient arena, brand names like Protonix and Pepcid and all that kind of stuff. But there are side effects to those. And in the critically ill, that's no different. So what are the current guideline recommendations? In summary here, modern ICU guidelines support a risk-based approach to stress ulcer prophylaxis. The key idea that they postulate is that we should use stress ulcer prophylaxis in critically ill patients with meaningful bleeding risk, right? We've kind of talked about this earlier in the episode. And that we should use either a PPI, a proton pump inhibitor, or an H2 receptor antagonist, right? These are things like pantoprazole would be a PPI, right? And it's commonly used. An H2 receptor antagonist would be like famotidine. These would be 2 very common workhorses of stress ulcer prophylaxis.
We should use low-dose prophylactic regimens, and we should stop prophylaxis early once that risk period ends. And this is super key. Sometimes we put patients on stress ulcer prophylaxis. We never discontinue it, even when they're out of that risk window. And then those patients sometimes even get discharged on that medication. And it is well validated and well studied that these medications over the cycle of a lifetime can have really significant adverse effects for patients. So it's incredibly important that we discontinue these medications when that risk period ends, and that we don't leave them on when we're transferring them to the floor to get continued and sometimes even discharged with. So the 2024 Society for Critical Care Medicine guideline moved away from the old rigid major minor risk factor counting approach and instead emphasized whether the patient has a net meaningful risk of clinically important bleeding. Now, up to this point, you might be sitting there saying, okay, this is a lot of vague terminology. Just keep hearing meaningful risk of clinically important bleeding. Agreed. Let's try to get into some of the actual specifics here. And if you want any of these specifics, this study guide, this PDF, is available on that Patreon page that we talked about. So definitely check that out. You can download it on there. If you want to have it with you, annotate it, take it with you, what have you, you can download this exact PDF, okay? So when to start stress ulcer prophylaxis? Well, the clearest guidelines talk about having critical illness plus a major bleeding factor. And the major bleeding factors talked about most commonly are shock, coagulopathy, or liver disease. And they get defined a little bit, in studies in the guideline evidence review. So coagulopathy would be someone who's thrombocytopenic or has a, prolonged INR, PT, PTT. And this is, again, not medical advice. Obviously, verify all these numbers. This is just for educational purposes, but that'd be coagulopathy. All right, shock, as we all hopefully realize, is need for vasopressors or, hypotension. Some say MAPA 70, others say MAPA 65 in terms of stress ulcer prophylaxis. But the concept here is anything that could cause hypoperfusion to tissues would be consistent with shock, right? Because that hypoperfusion is what puts you at risk for that mucosal injury. So, even if you're not profoundly hypotensive, but you got a markedly elevated lactic acid, you have a lot of end organ injury like AKI and transaminitis, and you're confused because you're not perfusing your brain. All that would suggest malperfusion, and the GI tract is experiencing that same malperfusion as the rest of the tissues, which is a risk factor for stress ulcers. All right, and then additional factors that may increase risk depending on the context. This is where we get a little bit vague, and even the guidelines are a little bit vague, and it opens it up to, kind of let you interpret it the way you will. But severe critical illness, they say. So, I think it's like one of those things where you might know it when you see it, but someone is severely ill. Maybe they're not in shock, but they're in severe ARDS. Neurocritical illness is a particular risk factor for stress ulcers. Acute kidney injury is on some lists. Anyone on therapeutic anticoagulation, anyone with a history of prior GI bleeding. All these things start to add up and could increase risk depending on the context. So these additional risk factors may influence judgment, but strongest guideline-supported factors remain shock, coagulopathy, and chronic liver disease. Now, interestingly, there's been, I think the classical teaching talks about mechanical ventilation, and we'll get into that. But the important guideline clarification here is that the current SCCM guidelines does not really use this one major or two minor risk factor thing. It talks about meaningful bleeding risk and low bleeding risk. And again, that meaningful bleeding risk often talks about shock. It often talks about liver disease, right? And it often talks about coagulopathy. But then it leaves open some interpretation with severe critical illness, neurocritically ill, and AKI, and all that kind of stuff. Now, in a lot of institutions and places, we have historically said that mechanical ventilation for more than 48 hours is a standalone indication for stress ulcer prophylaxis. we've worked at places where this is still the case. But modern guidance is more cautious than this. Modern guidance does not include this mechanical ventilation alone as a clearly established independent risk factor for clinically important stress-related GI bleeding. Now, mechanical ventilation with severe illness, potentially. Mechanical ventilation with shock or coagulopathy or liver disease, yes, certainly. But mechanical ventilation alone is not an automatic indication, at least per the best evidence that we have. So that's kind of probably a big change depending on where you all work and what exposure you've had. There's a lot of units out there that still use mechanical ventilation for more than 48 hours of blanket indication for stress ulcer prophylaxis. And that's kind of veered away from the evidence that we have. What about the role of enteral nutrition? Well, enteral nutrition does appear to be protective against stress-related bleeding. And this has a couple postulated mechanisms. One of those is maintenance of mucosal perfusion. As we feed the gut, it triggers our body to increase the blood flow to the gut, and that might improve mucosal perfusion. It supports mucosal barrier integrity, so feeding the gut helps maintain some degree of homeostasis with that mucosal barrier of the GI tract, and it buffers some gastric contents, right? You're kind of diluting out some of the gastric acidification that is going on when you're mixing those gastric contents with feeding. So there's a couple physiologic principles that may work in the patient's favor when they have enteral nutrition in terms of preventing stress-related bleeding. But what to do with this is still tough, right? So you could consider a low-risk ICU patient who's tolerating enteral nutrition may not need stress ulcer prophylaxis. But enteral nutrition alone does not override major bleeding risk factors. So if someone's in profound shock, well, I guess that's tough, because are you feeding that patient? That could be a whole nother episode. Let us know if you want us to make an episode on enteral nutrition and the critically ill and when to start it and all that good stuff. That'd probably be a good episode. But if you are feeding a patient, if they have other major bleeding risk factors, whether it be shock, whether it be coagulopathy, whether that be liver disease, etc., the feeding alone does not override the major bleeding risk factors, and you should still consider stress ulcer prophylaxis. So tube feeding lowers risk, but they do not make shock, coagulopathy, cirrhosis irrelevant. What about medication? So we've talked about the indications, we've talked about the evidence. Still a little bit vague, but we at least have some guidance there. We've talked about mechanical ventilation alone not being a reflexive indication for stress ulcer prophylaxis, despite some of the historical precedent there. But let's talk about the actual medications. What should you be using? What should you consider using? Well, the two medication classes recommended are the ones we've kind of intermittently mentioned throughout this episode, and that is proton pump inhibitors and histamine 2 receptor antagonists, right? Proton pump inhibitors classically would be pantoprazole, but there's certainly many of them. Histamine 2 receptor antagonists would classically be famotidine, at least in the United States. Both are considered acceptable first-line options. There's been discussion over time about sucralfate, but this is not a first-line option, and it is not something that should be used alone for stress ulcer prophylaxis in the classical patient. So which one is better? Is one better? PPIs versus H2 receptor antagonists? Well, proton pump inhibitors, as we talked about, some examples here. Pantoprazole, omeprazole, esomeprazole, lansoprazole. The advantages of these is that there's some stronger gastric acid suppression, the PPIs, likely better bleeding prevention, and they're commonly used, right? But there's some limitations there. When you compare them to H2 receptor antagonists, there is no clear mortality benefit between the two. So you can't say that one is better than the other from a mortality standpoint. But you might need more aggressive acid suppression in some patients, but you might not, right? So there's been a lot of talk over time on whether PPIs with their more significant gastric acid suppression actually increase risk in patients for things like pneumonia or C. diff or what have you. And there's been some trials that have gone back and forth. At this exact moment, the running theory is that PPIs do not increase your risk for those things any more than H2 receptor antagonists. But PPIs do have more aggressive acid suppression, and some folks might still feel like that increases the patient's risk for things like C. diff or pneumonias. But as we mentioned in this last point, large trials have not shown a dramatic safety signal to support that.
So when clinicians often lead towards PPIs, those with a really high GI bleeding concern probably should favor giving that patient a PPI rather than an H2 receptor antagonist. Multiple bleeding risk factors, prior upper GI bleeding, or desire for maximum bleeding prevention. So those at a really increased risk, consider going with a PPI rather than an H2 receptor antagonist, but just know, per the trials, there's no mortality benefit to doing this. And, there's some folks who think that the PPI might increase your risk for infectious complications, although, again, trials don't support that. All right, what about H2 receptor antagonists, H2RAs? Well, again, the workhorse here is famotidine, at least in the United States. And the advantages to this is, number one, again, it's effective prophylaxis. There's no difference in mortality between using the H2 receptor antagonist like famotidine or the PPI like pantoprazole. There's a little bit less potent acid suppression, which some folks would say is an advantage because it just takes that potential increase in infectious complications out of the equation. Again, echoing like a broken record that the trials do not support that there is an increased risk of infectious complications with PPIs. And famotidine has a long ICU track record. Limitations: it is probably somewhat less effective in preventing bleeding than PPIs. That is probably true, but again, no mortality difference in the trials. And just note that famotidine H2 receptor antagonists do require a renal dose adjustment. So when do clinicians often lead towards H2 receptor antagonists like famotidine over PPIs like pantoprazole? It's most commonly when prophylaxis is indicated, but bleeding risk is not extreme. Desire for a more conservative acid suppression approach, or to moderate risk patient rather than a very high-risk patient. Again, a lot of this at institutions is protocolized, so sometimes the protocols just grab for one or the other. But just note there is some nuance between the two, with the caveat being the large trial data does not suggest one is better or worse than the other in terms of H2 receptor antagonists versus PPIs. So what about typical dosing strategies? We just want to re-emphasize this is educational. All right, please follow your local guidelines or look things up before starting any of these medications. The dosing is just opinion and educational. All right, so common ICU dosing regimens from an educational standpoint. From PPI, pantoprazole 40 milligrams daily is pretty classical. Omeprazole 20 to 40 milligrams daily. And then H2 receptor antagonist, famotidine 20 milligrams twice daily. Although again, there's a renal dose adjustment that often needs to be made. And just know that either intravenous or enteral administration of these drugs is acceptable, depending on whether the gut is usable and reliable or not. So it does not have to be intravenous. So main trials that shape modern practice, if you want to get into a little bit of the nuance here, obviously this is just a brief overview of those trials. So if you want more detail, just look them up. They're easy to look up. So the SUP-ICU trial, stress ulcer prophylaxis -ICU trial. This was a trial that was a major placebo-controlled trial looking at pantoprazole versus placebo, right? So it wasn't pantoprazole versus something like famotidine. It was pantoprazole versus placebo in ICU patients considered at risk for GI bleeding. And it showed that pantoprazole did reduce clinically important GI bleeding, but it did not improve mortality. And it also did not show a major increase in infectious complications between pantoprazole and placebo. This included pneumonia, C. diff, myocardial ischemia as the main safety outcomes. So it was one of those trials that did not support the old notion that PPIs increase the risk of infectious complications. So this trial reinforced an important modern principle that stress ulcer prophylaxis, in this trial specifically a PPI, does reduce bleeding. That does not automatically translate into better survival, though, as there's no mortality difference. Although I would say that decreasing bleeding is really important, even if, modern medicine is really good at managing that bleeding, so there's not a mortality difference between the two groups, which is wonderful. But reducing clinically important GI bleeding, I would say, is a very big net positive. The PEPTIC trial. The PEPTIC trial looked at PPIs versus H2 receptor antagonists, so pantoprazole versus famotidine in mechanically ventilated ICU patients. And what it showed was no statistically significant mortality difference between the two. PPI seemed to offer a somewhat better bleeding prevention, although, again, this was not a statistically significant change. And then it was a crossover pragmatic trial design, so, these get a little complex in their interpretation. But the summary here would be that the peptic trial did not show a mortality difference between PPIs and H2 receptor antagonists. So this trial supports the idea that both PPIs and H2 receptor antagonists are reasonable. PPIs may have a bleeding prevented advantage, but there's no clear mortality winner. All right. And then the last trial would be I think it's the last one we put in here. Yep. The REVISE trial. The REVISE trial studied pantoprazole versus placebo in mechanically ventilated patients. And it just confirmed, what we saw with that SUP ICU trial, that pantoprazole reduced clinically important upper GI bleeding, but there's no mortality difference. And this strongly supports, again, the idea that acid suppression can prevent bleeding in higher risk patients, but that does not necessarily mean that mortality is different between the two. So if we were to summarize what these trials mean at the bedside, the major trials do support that stress ulcer prophylaxis reduces clinically important GI bleedings, that PPIs probably reduce bleeding a little more than H2 receptor antagonists, but that there's no mortality benefit between the two. So use stress ulcer prophylaxis when there's a meaningfully high bleeding risk. Do not use it automatically in low-risk patients. If bleeding prevention is your top priority, a PPI may be favorable, but guideline-supported, somewhat less aggressive options like H2 receptor antagonists are also reasonable. So when to stop stress ulcer prophylaxis? As we mentioned, this is massively important, and we all in critical care medicine could probably do a better job at this, because the reality is there's some momentum that happens when we transfer someone out of the ICU still on a PPI or an H2 receptor antagonist. And from trials, we know that a number of those patients get discharged home with it as well, and that over the long run, these medications do have significant side effects profiles. So these should not be continued indefinitely. Sometimes we call it a marmectomy when we're rounding, right? If we're going to transfer someone out, we need to perform a marmectomy to make sure we're discontinuing all the things that the patient no longer needs that we start in the ICU for their critical illness. So stop stress ulcer prophylaxis when critical illness resolves or their bleeding risk resolves, whether that be shock, coagulopathy. You can't really stop their liver disease, but if their critical illness has resolved or their major bleeding risk factor has resolved, please feel free to stop it. This is one of the most important stewardship points, as we've said a couple of times. So a common real-world mistake, just to try to really nail this home, is starting stress ulcer prophylaxis in ICU and then continuing it through transfer and discharge. All right. So if we talk about a couple common pitfalls, we're getting close to the end of the episode here. So some common pitfalls, just things to kind of throw out at you. One of those pitfalls is automatic stress ulcer prophylaxis for all ICU patients. Evidence does not support doing this, right? You need critical illness and a major bleeding risk factor, which are most commonly things like shock, things like coagulopathy, things like liver disease. Mechanical ventilation is not a sole indication for stress ulcer prophylaxis. And then another common pitfall is forgetting to stop stress ulcer prophylaxis. And then a fourth is using treatment dose acid suppression rather than the prophylactic dosing, using treatment dose gastric acid suppressions that you would do for like GI bleeding and stuff. So make sure you're doing the lowest dose you can. So bedside summary here: start stress ulcer prophylaxis with critically ill patients with a meaningful bleeding risk factor such as shock, coagulopathy, or chronic liver disease. Avoid routine stress ulcer prophylaxis when it's a low-risk patient, they're enterally fed and otherwise low risk, or they have mechanical ventilation alone, because these are not strong indications for stress ulcer prophylaxis in and of themselves. Agent of choice is a PPI versus an H2 receptor antagonist. There's no mortality difference between the two. PPIs do not seem to meaningfully increase the risk of infection, but they do seem to provide the strongest bleeding prevention. So take that into account when you're choosing your agent. Reassess the patient daily. Are they still critically ill? Do they still have a bleeding risk? And do they still need acid suppression? And when they don't, discontinue that medication so that they don't mistakenly get continued on it indefinitely. So stop the medication early and really make sure to perform that marmectomy before someone's being transferred out of the ICU.
All right, the last thing we have here is 3 practice questions on this topic to test your knowledge. If you have not done practice questions with us before, we will read the question, read the answer options, and then we go right into the answer. So if you need time to think about it, just make sure to pause the episode because we're going to go right into the answer. Question 1. They usually get more harder as we go on. Which ICU patient most clearly meets guideline-supported indications for stress ulcer prophylaxis? A. Mechanically ventilated patients without other risk factors. B. Patient with septic shock requiring vasopressors. C. Patient tolerating enteral nutrition without risk factors. Or D. Postoperative patients admitted for monitoring. Correct answer is, pause if you need to, B, right? Patients with septic shock requiring vasopressors. So the explanation here is that shock is one of the clearest major risk factors for clinically important stress-related GI bleeding. Current guidelines support stress ulcer prophylaxis in critically ill patients with meaningful bleeding risks, such as shock, coagulopathy, or chronic liver disease. Mechanical ventilation alone is not a strong standalone indication. All right, question number 2, a little bit harder. Which statement best reflects the major ICU trial evidence comparing PPIs and H2 receptor antagonists? A. H2 receptor antagonists clearly reduce mortality compared to PPIs. B. PPIs reduce clinically important GI bleeding more effectively than H2 receptor antagonists, but neither has shown a consistent mortality benefit. C. PPI should only be used for active GI bleeding. Or D. H2 receptor antagonists are no longer guideline supported. Pause if you need to. The correct answer here is also B. PPIs reduce clinically important GI bleeding more effectively than H2 receptor antagonists, but neither has shown a consistent mortality benefit. So the major ICU trials that we talked about support that PPIs probably provide somewhat better bleeding prevention. These were seen in the trials like Revise, and oh boy, are we going to forget the name of the other one? We're going to scroll back up. You'll have to forgive us. Here it is, Peptic. Revise and Peptic. See, we're learning too. Look at all of us learning together. Revise and Peptic were the 2 trials comparing the 2 that supported PPIs probably have better bleeding prevention, but neither has shown a clear mortality benefit. All right, last question. A critically ill patient with septic shock was started on pantoprazole for stress ulcer prophylaxis. 3 days later, vasopressors are off, INRs normalize, and platelets are stable. The patient is tolerating enteral nutrition. What is the best next step? A. Continue pantoprazole until hospital discharge. B. Increase to treatment-dosed pantoprazole. C. Switch to famotidine for the rest of the admission. Or D. Discontinue stress ulcer prophylaxis. We hope you get this one right. The correct answer is D. Discontinue stress ulcer prophylaxis, right? Guidelines emphasize stopping stress ulcer prophylaxis when critical illness and or major bleeding risk factors resolve. Do not continue it and perform your marmectomies before patients leave the intensive care unit. Right, everybody, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's topic is one that was actually requested by one of our Patreon or YouTube members, and that is feeding in the intensive care unit. And it's going to be an introduction to that. We're going to focus on why ICU nutrition matters, the different modalities we can use to provide nutrition, right? Enteral, oral, gastric, post-pyloric, parenteral, when we should do it, when we shouldn't do it. We'll talk about some of the kind of common complicating features, recurrent aspiration, gastric residuals, all that kind of stuff. And then at the end, we'll go through some practice questions to see what we have learned. The hope is by the end, you have a great grasp on some of the foundational knowledge around feeding in the ICU. And we probably will come out with a couple of other episodes and kind of advance in complexity and kind of more advanced understanding of nutrition in the ICU as time goes on. So let us know what you think. No further ado, though, let's dive in. Why ICU nutrition matters? Well, critical illness creates a hypermetabolic, inflammatory, catabolic state. We've all seen this, right? Patients lose muscle mass. They have respiratory muscle strength problems. It affects their immune reserve, their functional residual capacity, right? There's weakness that comes from this.
significant PT, physical therapy, OT, occupational therapy needs, it is very hard for patients to return to their previous baseline quickly. And, some of this is probably related to nutrition. Some of it might not be, right? Being sick is tough. Being in the bed is tough. But providing the body with nutrition is also important. So nutrition support is not just calories, it's organ support to some degree. One of the first major questions, though, is, well, what route should we use? How should we feed these patients? And that gets into core definitions. And before we go into this, we should have told you, if you want this study guide or PDF, what we are going through right now, you want to download it, annotate it, print it out, all of them are offered on our Patreon page in our Patreon community. We've been really excited about it. We've been growing like mad. We got tons and tons of emergency critical care educational content on there. Probably one of the largest collections there is out there, full ICU curriculums. And one of the things we have are study guides for all of our episodes. In addition to that, there's, practice question banks, ad-free videos, courses, medical education, post-clinical reviews. And we've had a lot of interest from folks, which has been so exciting. So if you're a big nerd like we are and you want to check that out, it is linked in the episode description. It's also in the pinned comment on YouTube. We'd love to see you there. So check that out. Okay, back to core definitions. Well, the first definition we're going to talk about is enteral nutrition, EN. And this just means nutrition derived through the gastrointestinal tract. So whether you eat or you deliver it to the stomach or you deliver it past the stomach, it is nutrition that goes through the gastrointestinal tract, right? Examples would just be an oral diet, what you and I do, or a diet through a nasogastric or orogastric tube, or a nasojejunal tube, a tube that goes through the nose into the jejunum, part of the small intestine, a PEG tube or PEJ tube, right? These are cutaneous tubes that go through the skin into the stomach or jejunum, right? All these are going to be enteral nutrition modalities. If the gut works, if our gastrointestinal tract is working, enteral nutrition in general is usually preferred, and we'll get more into that. The other way you can supply nutrition is parenteral. This is nutrition delivered directly to the venous system, right? This can be parenteral nutrition through a central vein, parenteral nutrition through a peripheral vein. This bypasses the GI tract and just delivers macronutrients directly into the bloodstream. So there's no, feeding orally involved, or enteral nutrition involved, which is using a previous definition to create a new definition. Great job over here. We're doing well. But yes, parenteral nutrition is delivered intravenously. It's macronutrients directly into the bloodstream. It does not involve the GI tract. Other definitions that we're going to talk about are trophic feedings. This is a very low rate enteral feeding. All right, so this is enteral. That means it goes through the GI tract, whether that's orally or through an NG tube or NJ tube or PEG tube, but it's a very low rate. All right, so it's not kind of full feeds. And the goal with trophic feedings is often to maintain gut integrity. Our guts have an incredibly complex ecosystem, whether that's microbes, whether that's immune function, and there's some evidence that suggests that continuing to stimulate the gut with trophic feeds helps maintain the integrity of that gut, stimulates enteric blood flow, and, gives us some calories, although not full calories. Some people call trophic feeding trickle feeds, right? You'll hear people say, let's start trickle tube feeds. And we also have to say none of this is intended to be acted upon as medical advice. All of it is just simply educational. So just wanted to put that out there as well. So yeah, trickle tube feeds, the kind of formal word for it is trophic tube feeds. And that is in comparison to full enteral feeding, right? Enteral uses the GI tract. Full means we've advanced it to the estimated caloric and protein goals for that patient. So remember, enteral nutrition uses the GI system, whether that's through the mouth or the stomach or the small intestine. Parenteral nutrition delivers macronutrients directly to the bloodstream through an IV. It does not use the GI tract. Trophic feeds are a type of enteral nutrition where you give very low rate enteral feeds. Full enteral feeds are when you have a nutritional volume that is appropriate for a patient's caloric and protein goals. All right, basic ICU feeding framework. We often ask ourselves a couple different questions. The first is, can the patient eat safely by mouth, just like they would normally at home? If the answer is yes, feed them by mouth. If the answer is no, the second question is, does the GI tract work, right? Do they have an ileus or bowel obstruction or mesenteric ischemia or a number of other conditions that we will describe, right? If the GI tract works, we should feed it. If it doesn't, then the third question is, do we need to start parenteral nutrition, IV nutrition? And the simple rule here is use the gut when you can, right? That's always the better option. But when the gut cannot be used and enteral nutrition is inadequate for too long, you should be thinking about parenteral nutrition, intravenous nutrition, and we'll get more into that. So route number 1, oral feeding. The answer to that first question, can the patient safely eat by mouth? The answer is yes. Then we should start with oral feeding, right? Best used for awake patients, patients who can swallow safely. This is really important, right? People who are sick sometimes lose their ability to swallow safely, right? Some of them need a swallow evaluation. But if you can swallow safely and you're a low aspiration risk, start oral feeding. The thing to remember, though, is you really got to monitor whether that patient's able to meet their caloric needs orally. Just because we're able to eat by mouth doesn't mean we actually have any appetite and want to eat by mouth. So sometimes patients just don't consume enough orally when they are sick because they're feeling so crummy, and that's something we need to monitor in case we need to intervene. Limitations here, many ICU patients cannot eat enough. We just talked about that, right? Are they delirious, weak, on high oxygen support, can't swallow safely, poor appetite, all these things. So sometimes for these patients, we're doing something called a calorie count, which is literally when we monitor how many calories they take in. All right, that's route 1, oral enteral nutrition. Route 2 is gastric enteral nutrition. This is where we bypass the mouth and deliver food directly into the stomach, right? This is usually through something like a nasogastric tube. A nasogastric tube goes through the nose. I don't know why we just started doing a terrible drawing. Here's a nose, here's a face. It kind of looks like a bird. So the tube goes through the nose, into the esophagus, and down into the tummy, right? And that tube sits in the stomach. It's a naso for nose, gastric for stomach tube, a nasogastric tube, also known as an NG tube. An orogastric tube goes through the mouth, through the esophagus into the stomach, often known as an OG tube, right? These OG tubes, it's really, you shouldn't be putting a tube in someone's mouth into their stomach unless they're, on like a ventilator or something, because it's very uncomfortable. It has to go past their gag reflex and all that, whereas a nasogastric tube bypasses that gag reflex. So still not a comfortable thing necessarily, but more comfortable than having a tube sit in someone's mouth. So these types of tubes, gastric enteral nutrition in general, most often used for patients on mechanical ventilation. Obviously, you can't swallow safely if you have a tube going through your mouth into your trachea and you're hooked up to a ventilator. Patients need to have a functioning GI tract still, right? They don't need to be able to swallow safely because you have a tube bypassing the swallow mechanism sitting right in the stomach, but you're still delivering food to the GI tract, right? This is enteral nutrition. So you need to have a functioning GI tract. And, patients, you should be cognizant that the patient is not a major aspiration risk or have gastric emptying issues. This is a little gray. It's tough to know, but if a patient is constantly if the patient is unable to empty their stomach contents, so they have gastric emptying issues, they're high risk to vomit that up, and then they can aspirate it. So you got to be careful with those patients. Advantages here are it's easy to place, it's fast to initiate, it's physiologic, we're still feeding the tummy, lower infection risk than parenteral nutrition when you give that IV nutrition, and it supports gut integrity, right? So this is a great thing. This is very common in the ICU. The common concerns, though, here are vomiting, aspiration, lots of feeding interruptions, when you make a patient NPO, you stop their tube feeds for different procedures. There's a lot of discussion on whether we should be stopping these tube feeds in every patient for procedures, but that's probably for a different episode. And then again, they need a functioning GI tract. They need to be empty their stomach and not aspirate what you're feeding them. Okay, so remember, route number 1 was oral, like a normal human. Route number 2 was gastric through an NG tube, a nasogastric tube, or an OG tube, an oral gastric tube. The other tube actually that you could do would be a PEG tube. This is a, tube that goes through the skin into the stomach. It's kind of a mini surgery that patients get when they need to have gastric feeding chronically. All right, route 3. This is something we don't do that often, but post-pyloric enteral nutrition. So that is feeding delivered beyond the stomach, usually to the duodenum or jejunum. And this could be a nasoduodenal tube. So when you're placing that tube through the nose, you're going into the stomach, and then you're going further out of the gastric pylorus, right, through the gastric pylorus and into the duodenum, the small intestine, right? So that tube's got to go through the stomach, through the duodenum, into the small intestine. This can be hard to do. It can be hard to place blindly a post-pyloric feeding tube, but this can be done, with EGD and other guidance too. And then there's jejunostomy tubes, which are tubes that go into the jejunum. Again, sometimes interventional radiology or gastroenterology will do that, EGD or under direct visualization. It's harder to do blind bedside. But this should be considered. We probably should do this more often, especially patients with high aspiration risk, recurrent vomiting, poor gastric emptying, because that was one of our concerns. I'm just looking at this drawing that we did. It's so bad. Please forgive us. But when patients can't empty their stomach, right, if you have gastric feeds going through an NG tube or OG tube or PEG tube, but those feeds aren't being emptied in the small intestine, they're just building up in the stomach, and eventually we'll have vomiting and potential aspiration. So if you can't empty the stomach, if you have recurrent vomiting or a high aspiration risk, or you have gastroparesis, or you're just not tolerating gastric feeds, you should consider post-pyloric feeding, because it will bypass that stomach. So you'll get past a lot of the recurrent vomiting, poor gastric emptying, gastroparesis issues by feeding that small intestine. And that's been guidance, which is one of the big kind of ICU nutrition societies, recommends post-pyloric feeding in patients at high risk for aspiration. So it comes supported. Advantages here: may reduce aspiration risk, useful when gastric feeds fail, but they are harder to place from a limitation standpoint, and because of that, it may delay feeding, and it does not eliminate aspiration risk completely. It decreases the aspiration risk, but does not eliminate it. All right, route 4 is parenteral nutrition. So far we had oral, gastric, post-pyloric. And these are the 3 ways we can give enteral nutrition. Remember, enteral nutrition was feeding the GI tract. The 4th is parenteral nutrition, which is feeding the bloodstream with macronutrients, so it does not use the GI tract. So parenteral nutrition is nutrition delivered intravenously, right? It's usually macronutrients: dextrose, amino acid, lipids, electrolytes, vitamins, trace elements. Usually there is a specialized pharmacist or someone who compounds the parenteral nutrition, and they adjust it based on the patient's needs, based on their electrolytes, their glucose, all that kind of stuff. But it does require this specialty pharmacist to compound that. This is best for non-functioning GI tracts. You cannot feed the GI tract because it is not functioning, right? So there's no way to provide that patient nutrition without parenteral nutrition. Bowel obstruction, severe ileus, mesenteric ischemia, high output fistula, which can't get distal feeding, severe malabsorption, inability to achieve adequate enteral nutrition over time, right? So all these things are primarily can't use GI tract, so can't give enteral nutrition safely, with this kind of subsequent point of severe malabsorption, aka the GI tract can't absorb nutrients, or inability to achieve appropriate calories with enteral nutrition, right? All those would be a reason to consider parenteral nutrition. There are some risks here though, right? So catheter-related infections are a concern. A lot of parenteral nutrition needs to go through a central line, right? And central lines have higher bloodstream infection risk. That CLABSI catheter central line associated bloodstream infections. We just blanked on the abbreviation name. We're doing great today. Central line associated bloodstream infections, CLABSIs, are a big focus, and parenteral nutrition often needs to go through a central line. Not every time, but often. Hyperglycemia is a risk. You got to get the glucose, the dextrose, and insulin balance right. Electrolyte disturbances, because we're compounding what electrolytes are in there, and then we're delivering it directly to the bloodstream. There's no kind of digestion or absorption that is happening. Refeeding syndrome, liver dysfunction, and overfeeding, right? Anytime we are delivering nutrients directly to the bloodstream, we take out the body's ability to absorb the nutrients they want in a more physiologic way. We risk all these things, right? Because we're kind of taking over that function by delivering those nutrients directly to the bloodstream. So enteral versus parenteral high yield concepts. Historically, enteral nutrients, so that's feeding the GI tract, was strongly favored. It's physiologic and it may reduce infectious complications. There's been some trials since then, though, that suggest maybe the route itself might matter less than being thoughtful and avoiding harm from overfeeding, under monitoring, or inappropriate patient selection for the different feeding modalities. So there's a trial, and we'll talk about trials a little bit more, called the Calories trial, that looked at early parenteral nutrition, and it did not significantly change 30-day mortality compared to early enteral nutrition, right? So this suggests that the IV route and the oral, well, not oral, but the GI tract route patients could receive either of those routes, and the 30-day mortality was similar. So the practical takeaway here is enteral nutrition is still usually first line when the gut works, but parenteral nutrition is not automatically bad, right? And it can be appropriate when enteral nutrition cannot be safely or adequately delivered. So don't shy away from it if that's what the patient needs. All right, when to start feeding. Remember, this is not medical advice, it's just educational, but the general principle here is that most guidelines support early enteral nutrition in critically ill patients who are unable to eat and have a functioning GI tract. But what does that mean? The common target here is to start enteral nutrition usually within 24 to 48 hours of ICU admission. This is though after resuscitation is underway and the patient is improving from a hemodynamic standpoint. We'll get more into that. It's really, really important. Those ASPEN and SCCM guidelines address early nutrition and support early nutrition, but that's not they have to start getting feeds within 4 hours of coming to the ICU, right? You got a day or two, and they should be resuscitated and hemodynamically improving to make sure that they can perfuse their gut enough to absorb that nutrition. When to hold or delay enteral feeds, and this gets into that hemodynamic discussion. So uncontrolled shock. What happens when you give enteral nutrition, when you feed the gut, right? You get vasodilation to the mesenteric vessels so that they can perfuse your gut more so you can digest that food and absorb nutrition. If you're unable to get adequate blood flow to your mesentery, even though those cells need more blood flow, that is when mesenteric ischemia can happen, right? So in patients in uncontrolled shock, feeding them can be very dangerous. It can cause mesenteric ischemia. So uncontrolled shock, escalating vasopressor, severe hypoxemia, active bowel ischemia, bowel obstruction, uncontrolled GI bleeding, severe ileus with intolerance. All these would be reasons that you should delay enteral nutrition. And I think the one we run into most is that significant hemodynamic compromise. So vasopressors in general, they're not an absolute contraindication, but they have to be controlled and improving. Uncontrolled or escalating shock is very high risk for mesenteric ischemia. There's no firm absolute what dose of vasopressors, this or that. A rule to consider from an educational standpoint would be if your vasopressors are improving and the perfusion of that patient's organs are improving and stabilizing, then that supports that hopefully the gut perfusion can accommodate enteral nutrition. But there's no kind of hard or fast rule there. Everybody's a little different. Feeding on vasopressors in general, now that we have set the stage, this is one of the most practical ICU questions. Educational approach here is if a patient is in shock, avoid feeding during active uncontrolled shock, as we talked about. Consider trophic enteral nutrition while shock is improving, right? Trophic is slow, kind of those quote-unquote trickle feeds, rather than cranking them up to full feed. Start low, advance cautiously, monitor for signs of intolerance, right? Worsening abdominal distension, vomiting, rising lactate, abdominal pain, feeding intolerance. These should be actively monitored for if you are starting feeds in somebody who is quite sick, right? Even if their shock is improving and their hemodynamics are improving, if you're starting trophic feeds, you have to make sure that their GI tract is tolerating that. All these would be signs of possible blossoming mesenteric ischemia, which can be significant and detrimental to a patient, right? The concern is that non-occlusive bowel ischemia, rare, but it is catastrophic when it happens. So what about trophic versus full feeds? Well, in early critical illness, immediately forcing full calories may not improve outcomes and may actually increase intolerance. Right? So the Eden trial looked at acute lung injury specifically. We've talked a lot about acute lung injury and ARDS. Actually, in our Patreon community, there's a ton practice questions, mini courses, study guides, ad-free videos in one of our collections on that. We have collections on mechanical ventilation, renal replacement therapy, and shock, and cardiovascular, respiratory physiology, and a whole bunch of other things. So again, if you're a big nerd like us, we'd love for you to check it out. But anyways, the Eden trial looked specifically at patients with acute lung injury, so take that for what it's worth. But they found that initial trophic feeding, right, those slow, quote-unquote, trickle tube feeds, compared with full enteral feeding, did not change ventilator-free days, mortality, or infectious complications. So practically speaking, for many ICU patients, especially during that acute phase, trophic feeding is probably reasonable rather than trying to, slam them with full feeds right away. All right, what about refeeding syndrome? This is something we should always be thinking about in our critically ill patients. Refeeding syndrome is essentially dangerous electrolyte shifts after nutrition is restarted in malnourished patients. And this is often driven by insulin-mediated intracellular shifts. Hypophosphatemia is classic, so make sure you are testing that phosphate because we don't often send that routinely in everybody, although some places do. I guess we sometimes do. But hypophosphatemia is a big one. It can be deadly, right? Our ATP need phosphate. So if the body has none, it can't make any ATP. Other electrolytes, hypokalemia, hypomagnesemia, fluid retention are all concerns in refeeding syndrome. So high-risk patients are patients with prolonged starvation, alcohol use disorder, severe malnutrition, eating disorder, significant weight loss, chronic poor intake, right? This makes sense. These are patients who are high risk for refeeding because they have not been getting feeds or adequate feeds for quite some time. So to prevent it, start feed slowly, right? We'd already talked about trophic feeding being reasonable. So if someone's highly malnourished or has prolonged starvation, they start to show electrolyte derangements, trophic feeds. Make sure you give thiamine. Monitor that phosphorus, potassium, magnesium with a shout out again to the phosphorus because that is one that'll get hypophosphatemic. That's classic in refeeding syndrome. And replete those electrolytes aggressively. All right, another kind of feeding thing we talked about, gastric residual volumes. I giggle because there's a lot of gray here and things have evolved over time. So historically, and maybe still at some institutions, but historically, we were checking gastric residual volumes. Essentially, that is like you check how much is left in the stomach, and that is the gastric residual volume. That's how much has not passed from the stomach into the small intestine. And we used to use that number to be like, they're not tolerating feeds, stop the tube feeds because there's high gastric residual volumes. But then some trials came out, and nowadays we don't necessarily do that, right? So we're not classically and routinely checking gastric residual volumes unless we have a reason to, other than just, routinely doing it. So modern practice is less aggressive about stopping feeds based on residuals alone, because in these trials it was poorly predictive of aspiration, and we actually just found that we held tube feeds more often without actually improving any outcomes. What we do check, though, are abdominal distension, vomiting, regurgitation, certainly abdominal pain, aspiration events. All those are ways we check to see if a patient is tolerating tube feeds rather than routinely checking gastric residual volumes. All right, aspiration risk reduction, special ICU situations. Then we got some practice questions, and that will be that. So aspiration risk reduction, these are hopefully somewhat straightforward things that we're all already doing in our sick patients, but head to bed elevation, oral care, avoid unnecessary deep sedation, seems obvious. The one thing that we should probably do more that we don't do is consider post-pyloric feeding in high-risk patients, right? Aspen, one of the big societies, as we mentioned, supports that. Prokinetics we didn't talk about, but there are some medications that can help gastric emptying, and then just continue to assess, right, vomiting risk in that abdominal exam. All right, special ICU situations. Mechanical ventilation. Patients on mechanical ventilation are often receiving gastric enteral nutrition if they're hemodynamically stable, right? That is most often through a nasogastric tube or an orogastric tube. Prone positioning. We can still feed enterally patients at prone positioning. We just got to be careful and monitor them. Pancreatitis, right? Early enteral nutrition is generally favored over parenteral nutrition in pancreatitis. Open abdomen and trauma, these patients have high protein needs, so be thoughtful about that. And then severe malnutrition, avoid refeeding, feed slowly, make sure you check electrolytes, including phosphorus. A couple trials here, we won't belabor them, but we just wanted to put them here because we mentioned them in this episode. The Calories trial, which compared early enteral nutrition versus early parenteral nutrition. No significant difference in 30-day mortality. The Eden trial compared trophic feeding to full enteral feeding in acute lung injury. Trophic feeding did not affect outcomes. And then early versus late parenteral nutrition, there's been a couple trials here, and the takeaway from them often is avoid reflexively chasing full caloric targets with early parenteral nutrition, but do consider parenteral nutrition in those that you've been unable to achieve adequate enteral nutrition over time. All right, here is a little chart of some practical ways in which we can think about route of nutrition. Some of this is probably going to be obvious, but just to speak it out loud, if you're awake, if the patient's awake and safe to swallow, oral diet. If they're intubated, they're stable, they have a working gut, gastric enteral nutrition. If they're high aspiration risk or have gastric intolerance, consider post-pyloric enteral nutrition. If they have a persistent non-functioning GI tract, consider parenteral nutrition. Early shock, escalating vasopressors, hold tube feeds, or consider starting trophic feeds, but only if they're improving. Severe malnutrition and unable to use the gut, do consider earlier parenteral nutrition, right? We find that patients with severe malnutrition at baseline should probably be fed earlier, right? Even though there's some trials that suggest if you don't have severe malnutrition, you do not need to get kind of immediate earlier parenteral nutrition. But the severe malnourished patient probably should get early parenteral nutrition if they can't tolerate enteral nutrition. Poor intake after several days despite enteral nutrition attempts, consider supplemental parenteral nutrition, right? So that's after several days in someone who is not severely malnourished. All right, some high-yield board pearls. If the gut works, use it. Enteral nutrition is preferred for most ICU patients. Gastric feeding is first line. Post-pyloric feeding is useful in high aspiration. Parenteral nutrition is appropriate if enteral nutrition is contraindicated or inadequate, but it does not need to be started immediately unless the patient has severe malnutrition, malnourishment at baseline. Early trophic feeds are often reasonable in patients whose hemodynamics are improving. Do not chase full calories too aggressively in the first few days. Protein matters. Watch for refeeding syndrome. Don't forget about the phosphorus, and delay enteral nutrition in uncontrolled shock. All right, last but not least, we have 3 practice questions to see if we have learned something, right? They will progress in degree of difficulty. If you have not done practice questions with us before, we will read the question, read the answer option, and then we'll dive right into the answer. So if you need more time to think about it, just make sure to pause the episode. Question number 1. An intubated ICU patient is hemodynamically stable and has a functioning GI tract, but they cannot eat by mouth. What is the preferred initial route of nutrition? A, parenteral nutrition. B, peripheral parenteral nutrition. Sorry, A was central parenteral nutrition. B was peripheral parenteral nutrition. C, gastric enteral nutrition. nutrition, or D, no nutrition for 7 days. Pause here if you need to. The correct answer is C, gastric enteral nutrition. So remember, for most critically ill patients with a functioning GI tract, enteral nutrition is preferred. If they can't tolerate it orally, we should do it gastrically through a nasogastric or orogastric tube, and this is a common initial approach. All right, question 2. A mechanically ventilated patient repeatedly vomits gastric tube feeds and is considered high risk for aspiration. What route should be considered? A, post-pyloric enteral nutrition. B, immediate long-term TPN, which is parenteral nutrition. C, oral diet. Or D, just stop nutrition indefinitely. Correct answer, pause if you need to, is A, post-pyloric enteral nutrition. So remember, post-pyloric feeding should be considered when gastric feeding is poorly tolerated or aspiration risk is high. This allows delivery of nutrients beyond the stomach, and it may reduce the aspiration risk in selected patients. Last question, and then everybody can go enjoy their day. A malnourished patient is started on tube feeds after prolonged poor intake. The next day, phosphorus, potassium, magnesium drop significantly. What syndrome is most likely? A, propofol infusion syndrome. B, refeeding syndrome. C, tumor lysis syndrome. Or D, acute mesenteric ischemia. Pause if you need to. The correct answer is B, refeeding syndrome. So refeeding syndrome occurs when nutrition is restarted after prolonged starvation or malnutrition. The insulin release drives hypophosphatemia, hypokalemia, hypomagnesemia, causing electrolyte depletion that can be quite dangerous.
All right, everybody, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day. We've had a really busy kind of clinical month in terms of sick patients and lots of them and all that jazz. So lots of kind of intellectually stimulating cases, although that certainly means people are sick, which is never a good thing. You know, we had a kind of an interesting case if I could just take a quick 60 seconds of your time, I wanted to introduce our newest Whiteboard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. A middle to elderly age female. She came in short of breath, febrile, hypoxemic. Chest x-ray showed bilateral interstitial opacities. You know, most concerning for pneumonia given her clinical history, but other things can't rule out inflammation, can't rule out edema, all that jazz. She certainly wasn't fluid overloaded. Her bedside ultrasound had preserved biventricular function, so certainly didn't seem to be pulmonary edema. Couldn't necessarily rule out an inflammatory condition, but at the time, took a stand and started treating for pneumonia. And then interestingly enough, her urine Legionella was negative, but then the Legionella from her BAL ended up being positive. So a sick Legionella pneumonia. She ended up developing ARDS, severe, had to be prone, deep sedation, you know, all that stuff. So quite sick. But those urine Legionella test sensitivity and specificity for any test is not 100%. So it's always a good reminder, right? If you have a high pretest probability for Legionella, those urine Legionella tests only test for several, and granted the most common, but several serotypes of Legionella. So they don't cover every serotype of Legionella, and if your pretest probability is high enough, even if the urine Legionella is negative, there's an argument there that maybe you should continue treatment with zithromycin rather than stopping it early or switching to doxycycline or what have you. So classic case of Legionella pneumonia, unfortunately complicated by severe ARDS. But anyway, not the topic for today. Today we're going to be talking about spontaneous breathing trials, a cornerstone of all intensive care units and kind of critical care medicine. So today in this video, or podcast if you're listening to it online. We keep forgetting we have a podcast, but it's very exciting. Check it out. In this episode, we're going to talk about what spontaneous breathing trials are in terms of goal, timing, duration. We're going to talk about how to do them, and we'll talk about a couple different methods, including TPEEP trials, pressure support trials, CPAP trials. We'll talk about a couple of the studies around that. We'll then go into how to tell if a patient is doing well on their spontaneous breathing trial. We'll mention the RSBI, and again, talk a little bit about some trials around the RSBI. Then we'll get into key considerations
questions. We'll have a comparison table for TP's trials versus pressure support trials for CPAP trials. And at the end, we'll go over a couple practice questions. So stick around for all those. We would love to see you out till the end. And no further ado, spontaneous breathing trials. So what are spontaneous breathing trials? Well, a spontaneous breathing trial, as many of us know, is kind of the gold standard bedside assessment tool to determine whether a patient can safely be liberated from mechanical ventilation, right? So it's an evaluation on the patient's ability to breathe without significant ventilatory support, right? A way to simulate extubated conditions as a way to know or understand if a patient might be ready to be liberated from mechanical ventilation. So the goal here is we're trying to identify the readiness for extubation. A really important thing. Obviously, you don't want to leave anybody on the ventilator longer than you have to. There's certainly complications that can come with being on mechanical ventilation, ranging from just ventilator-associated lung injury to ventilator-associated pneumonia, sedation, delirium, all that stuff. So getting patients liberated from mechanical ventilation is critically important, one of kind of the cornerstones of critical care medicine. So the goal is to identify who's ready to come off the vent. Timing for spontaneous breathing trials, in general, and we'll dive more into the details on this, but in general, we're usually doing this after improvement in the underlying illness, right? What caused them to be intubated? And have we improved that enough to no longer need the ventilator, right? If the cause was that they were completely obtunded and unresponsive, are they awake now? If the cause was they had profound hypoxemia from pneumonia, is their pneumonia improving, right? All these things make sense. So have we addressed the underlying cause in a way in which we think they might not need mechanical ventilation anymore? Hemodynamic stability is another one. There's lots of gray to hemodynamic stability. The old adage used to be that you need to be totally stable, off vasopressors, the whole gambit. Now we're starting to understand that, you probably don't have to be totally off vasopressors. How much vasopressors are reasonable to come off the vent? Still an unanswered question. But some degree of hemodynamic stability, or maybe the more appropriate way to contextualize it, would be hemodynamic improvement. If you were on 30 micrograms per minute of norepinephrine and vasopressin, and that vasopressin's now off and your norepinephrine's down to, 5 or 8 micrograms per minute, maybe that's a patient who, even though they're still on vasopressors, you could consider liberating from the ventilator. This is not medical advice, never is. You should certainly verify all this before acting on it. We have disclaimers in the episode description and at the end of the episode, but anecdotally, our practice pattern, we're okay liberating patients from mechanical ventilation who are still on vasopressors, assuming we're improving their underlying illness. And then the last thing is adequate oxygenation and ventilation, obviously. So, I think many people, and we'll go into this more, many people would put a PEEP of less than 10 and an FiO2 of less than 60% as kind of two oxygenation goals before you can put someone on a spontaneous breathing trial. Some people are more particular, right? Some people talk about a PEEP of less than 8 and FiO2 of 40%. Some people maybe are a little more aggressive. Anecdotally, again, we use this PEEP less than 10, FiO2 less than 60% personally. And the typical duration of these spontaneous breathing trials, 30 to 120 minutes is probably reasonable. Some of the trials used 30 minutes before they extubated patients. Other people use a little bit of longer time frames. So 30 to 120 minutes, again, lots of gray here, which is good. That's why we're doing this video, so you can kind of hear a little bit of insight and practice patterns on that. So how do we actually do the spontaneous breathing trial? Well, it'd be easy if there's just one way to do it, but there's not. So the first thing when you're talking about it is, do they meet some of those prerequisites we mentioned, right? FiO2 less than 60%, PEEP less than 10, depending on who you are. Might vary per patient, but are they oxygenating well enough without significant ventilator support? Are they ventilating, right? Are they not hypercapnic? Do they not have acute hypercapnia where they're able to ventilate well enough on their own? Do they have some degree of hemodynamic stability or hemodynamic improvement? Do they have an adequate mental status? Can they protect their airway? If you were to extubate them, are they able to protect their airway? Do they have a cough? Are they awake enough to spontaneously ventilate on their own? Are they strong enough to do that? These are some of the soft indicators that someone is ready to come off the vent, potentially. And then the last thing is secretions, or can they manage their own secretions? And this is tough because a lot of times we're like, oh, they have significant secretions. What do you do with that? Gosh, we don't know what to do with that. If they have a strong cough, hopefully they can mobilize those secretions on their own. If they have a weak cough and lots of secretions, maybe that's someone you give a little more time on the vent. Tough to say, but secretions is something that you should at least evaluate for and think about before you liberate someone from mechanical ventilation. And then the other thing, like anticipated procedures, are they going to the operating room in 5 hours? If so, maybe you leave them on the ventilator. Do they need a MRI of their brain and a whole spine in 2 hours? That's a long test. Maybe leave them on the ventilator. So just kind of anticipated clinical course is another thing to think about. So if you've decided that, yes, they meet the prerequisites, and yes, you want to do a spontaneous breathing trial, well, what the heck do you do then? What are the different methods to do a spontaneous breathing trial? We're going to talk about the 2 less common methods, and then we'll talk about the more common mainstream method. The 2 less common methods are a T-piece trial and a CPAP trial. And I want to be very specific with the verbiage here, because at times people call a pressure support trial a CPAP trial, and that's not necessarily true, and we'll get into that more. But starting with the T-piece trial, this used to be much more mainstream. We personally don't really do T-piece trials. We've maybe done it once or twice for kind of weird, unique situations. But in general, we don't do T-piece trials. And what a T-piece trial is you literally take someone off of the ventilator and you let them breathe through their endotracheal tube just hooked up to supplemental oxygen. There's no ventilator assistance at all. There's no PEEP. There's no inspiratory pressure. There's nothing. They're breathing through the endotracheal tube hooked up to wall oxygen. And there's some trial data to suggest that this isn't necessarily the best modality to use for a spontaneous breathing trial. In fact, outcomes were worse. And again, we'll talk about that trial in a second. But it makes sense that outcomes might be worse, right? Because you essentially have a straw, aka the endotracheal tube, going into someone's airway, and you're taking away all support and just having that patient try to breathe through that straw. So they don't have any PEEP, which means they can get alveolar collapse and atelectasis. Right? You don't have any inspiratory pressure. That inspiratory pressure, the pressure that is delivered during a breath, kind of gets over the resistance of the endotracheal tube. Try just breathing through a straw. That's hard, right? Now imagine being on a ventilator, being taken off that ventilator and being asked to breathe through that straw. So T-piece trials are not mainstream anymore, and for good reason, which we'll talk about. The other one we wanted to talk about that isn't commonly used is an actual CPAP trial. And we sometimes call pressure support trials CPAP trials, but an actual CPAP trial is that you just leave the patient on PEEP, but you take away all inspiratory pressure. So what this means is, the patient's still on a PEEP of 5, but otherwise they're just breathing through the endotracheal tube themselves. There's no inspiratory assistance. So you still run into the resistance of that endotracheal tube, because every time the patient takes a breath, they have to suck air through that endotracheal tube without any assistance. There's still increased airway, there's still increased resistance trying to suck air through that endotracheal tube. And as a comparison to help that make sense, that gets into the more common approach to vent liberation and spontaneous breathing trials, which is a pressure support trial using pressure support ventilation. And what this is the most common way we do spontaneous breathing trials in the ICU, pressure support trials. And we essentially leave the ventilator providing a PEEP, just like it would for the CPAP trial, right? A positive end expiratory pressure. And usually that's minimal. Usually that's 5. But again, some people talk about less than 10. Some people talk about less than 8. But 5 would be minimal. We leave a little bit of PEEP. And then we actually provide some pressure support, some inspiratory pressure support, anywhere in the realm of 5 to 8 above the PEEP. 5 being minimal, 8 being a little bit higher. But anything greater than 8 is a little more significant in terms of support, which I'll talk more about in a minute. But just to lay this out, so what happens is the patient's on the vent. You switch the mode of the ventilator to pressure support. And that ventilator does not deliver any breaths except when the patient triggers it. So if the patient doesn't take any breaths on their own, the vent doesn't give them any breaths. They're completely apneic until you eventually get to the apnea alarm, in which case the ventilator then has a backup mode that kicks in. But when the patient goes to take a breath, the ventilator senses that and it delivers a certain amount of inspiratory pressure, that pressure support, 5 millimeters of mercury, 7 millimeters of mercury, some type of inspiratory pressure. And the thought there is it's just enough inspiratory pressure to get over the resistance of the endotracheal tube. So it's not intended to provide actual inspiratory support. It's just intended to provide enough pressure to get past that resistance of the endotracheal tube. And then obviously you leave some PEEP on like we talked about. And that is the most common way we do spontaneous breathing trials, this pressure support trial. And as you can see then, the difference between the pressure support trial and a CPAP trial is the CPAP trial just has PEEP. It doesn't have any of that inspiratory support. And a TP's trial doesn't have PEEP or inspiratory support. You're just trying to suck air through that ET tube. So if we go into one of the trials that looked at pressure support trials versus TP's trials, it's a trial by Thill et al., 2016, published in JAMA, and it was a multi-center RCT, had about 1,000 patients in it, and they compared pressure support ventilation, where you have that inspiratory pressure and a PEEP, right? Just enough inspiratory pressure to get over the resistance of the endotracheal tube, somewhere around 5 to 8 centimeters of water, millimeters of mercury, and minimal PEEP, somewhere between 5 and 8, just to prevent atelectasis, versus a TP's trial. Remember we said TP's trial means you just take them off the ventilator and attach their ET tube to supplemental oxygen. And what they found in this was that pressure support trials were associated with lower extubation failure rates than the TP's trial, especially in high-risk patients, older folks, COPD, cardiac disease. And that's really interesting, right? Because it's saying that in patients you did the TP's trial on, you were more likely to have extubation failure. And you start to wonder, is that because you took away the PEEP and everything, and that patient got atelectasis and lobar collapse and all that jazz, and then you extubated them, and they had more trouble remaining extubated? Then the pressure support trial, where you have some inspiratory pressure and some PEEP still there to maintain recruitment, get over that endotracheal tube resistance. So from this trial, it supported the use of pressure support trials rather than TP's trials as the most physiologically relevant, patient-friendly SBT method, which is why not many people do TP's trials anymore. All right, so going into pressure support trials, since that's kind of the main way in which we try to do spontaneous breathing trials, this is the most common modern approach. And as we talked about, the endotracheal tube adds resistance when you try to breathe through it. So a small amount of inspiratory pressure helps overcome that resistance, which is actually more similar to kind of that normal physiologic airway after you extubate them, right? When you extubate them, you're not giving them a straw to breathe through, you're just letting them breathe normally. And a pressure support trial mimics that extubated state better. Typical settings, as we talked about, is an inspiratory pressure, also known as a pressure support, of 5 to 8, and a PEEP of, somewhere around 5, although some people would say less than 10, some people would say less than 8, and an FiO2 of less than 60%, although again, some people would say less than 50, or even 40 or less. So some variability in the PEEP and FiO2, but do note that this pressure support, this inspiratory pressure of 5 to 8 centimeters, if you start to increase that inspiratory pressure higher than that, you're no longer just overcoming the resistance of the endotracheal tube, you're actually providing them with significant inspiratory pressure support. And that's almost like pressure control. The pressure control mode of ventilation, where you're providing an inspiratory pressure to the patient to help them breathe. So you really want to make sure this pressure support is minimal. If you're starting to get a pressure support at 10 or 12 or 14, that is essentially pressure control. Obviously, you are still in a pressure support mode, but the amount of inspiratory pressure you're providing is significant. That is not mimicking, just enough inspiratory pressure to get over the resistance of the endotracheal tube. That's significant support. So this minimal pressure support number of 5 to 8 inspiratory pressure, 5 to 8 millimeters of mercury, is critical when you're doing these pressure support trials. All right, how to tell if a patient is doing well? Well, the first thing you should look at is the vital signs, right? Have they gotten super tachycardic all of a sudden because they're an extremis, heart rate of 120, 140? Obviously, they're not doing well then. Have they gotten hypotensive or hypertensive? Also maybe an indication that they're having trouble. Now, it's tough, right? Is it because of the wean and sedation? Is it because they're uncomfortable on the ventilator? All these things play a role, but vital sign derangements do imply that patients are much higher risk once you extubate them. Can they still oxygenate, right? Are they maintaining their SpO2 above 90? If you send a gas, a P to F ratio greater than 200, but really the message here is, are they still able to oxygenate while on a pressure support trial on the vent? Because if they're getting hypoxemic, that might indicate they're not ready to be liberated from the ventilator. Same thing with ventilation. Are they still able to ventilate adequately? They're not getting more hypercapnic. Some people routinely send gases when patients are on pressure support trials. We don't tend to do that unless we have something we're worried about. Sometimes we'll leave them on end tidal and make sure there isn't some big jump in their end tidal CO2 on the monitor. But obviously user preference on that one. one, but are they able to adequately oxygenate and ventilate? And then is their mental status still stable? Did you put them on pressure support and now all of a sudden they're obtunded and unresponsive, maybe because they're hypercapnic, right? Their mental status has to remain stable. And then do they have a tolerable work of breathing? They're not diaphoretic, they're not using accessory muscles, they're not belly breathing, they're not super tachypnic, right? Do they have a tolerable and stable work of breathing is the other critical thing. And this is all very subjective to a degree. You're looking at the patient, you're like, what do they look like? How are they breathing? Do they look comfortable, et cetera, et cetera. When we try to make this process more objective, one of the common markers people talk about is something called the Rapid Shallow Breathing Index, the RSBI. Some people call it the RSBI. And the Rapid Shallow Breathing Index is a math equation. It is the respiratory rate divided by the tidal volume in liters, okay? So respiratory rate divided by tidal volume in liters. And when people have studied this, if we think about what this means, it essentially means that they're breathing comfortably, so the respiratory rate is reasonably low, and that they're pulling high enough tidal volumes. Because you want the RSBI low. Less than 105 has been a good predictor of successful extubation. Now we'll go into the trial, one of the big trials on the RSBI, because it's not perfect, so you should always use it, with your clinical judgment. It's not an end-all be-all, but it's maybe an easy place to start, especially for trainees or people early in the field who kind of want something more graspable to help them understand if a patient can be liberated. The RSBI is a reasonable place to start, but it's not the end-all be-all by any means. Okay, so respiratory rate divided by tidal volume in liters. So one of the newer trials on this was from 2016. I don't know how to pronounce their name, apologies, but Tanios et al. Published in Critical Care Medicine. And it was a prospective multi-center observational study. Okay, so this is not a randomized control trial. And it looked at the Rapid Shallow Breathing Index in ICUs. And it was after there was this trial in 1991 by Yang and Tobin, which was kind of the OG RSBI trial, that showed a really good sensitivity and predictive value of the RSBI. But then Tanios et al. Went and tried to see if they could validate this. And they looked at about 900 adult ICU patients. It was mixed medical, surgical, trauma, and neuro ICUs. They looked at all mechanically ventilated patients deemed ready for weaning, right? So the patients that met those other criteria: hemodynamic stability, oxygenating appropriately, ventilating appropriately, mental status improving, etc., etc. And the primary outcome was extubation success versus failure at 48 hours. So did they need to be re-intubated by the 48-hour mark? And they used the RSBI cutoff of less than 105. And the results here were that those who had an RSBI less than 105, still it was associated with a higher probability of extubation success, but it was fairly modest in terms of the results compared to the original 1991 trial. There are still many patients with an RSBI of less than 105 that failed extubation, and some patients with an RSBI of greater than 105 that had successful extubations. So all this to say, that this is one marker amongst many markers you should be thinking about when you're thinking about liberating a patient from mechanical ventilation. As we said, a good place to start, but not the end-all be-all. Do note that this was an observational trial. It was not randomized. They looked only at an RSBI less than 105, not like multiple different RSBIs. And there's some things you couldn't really account for: airway protection, secretion burden, all that kind of stuff, which obviously can affect extubation failures. So bottom line here, RSBIs, maybe, a screening tool or just one piece of data, but its predictive accuracy is not absolute, and you should use your clinical judgment and some of these other kind of clinical assessment strategies in addition to the RSBI to help guide you. So with that being said, key considerations, signs of failure would be severe tachypnea, hypoxemia, tachycardia, hypertension or hypotension, agitation, diaphoresis, right? Anything that looks like there's increased work of breathing. Trial duration that we said is 30 to 120 minutes, variability there. Failure is usually declared earlier if there's intolerance. And the big thing here, and we probably should have said this earlier, is there is incredibly robust evidence that daily spontaneous breathing trials and sedation interruptions reduce ventilator days and improve mortality. So all patients, we cannot stress it enough, all patients that qualify should have daily SBT, spontaneous breathing trials, and SAT, sedation vacations. Every single patient that improves mortality and reduces ventilator days. Absolutely it does. This should happen for all patients. All right, to end here, we'll have some practice questions, but we just put a table in here, and every one of these study guides will be on our Patreon page, which is in the video episode description. And we upload all of our study guides, practice questions, ad-free videos, med-ed posts, discussions, all that good stuff. So definitely check that out. We'd love for you to join or hop on board. But yeah, the study guide will be on there if you're interested in accessing the study guide, because this table here is kind of a comparison of spontaneous breathing trial methods, including the TPEES trial, pressure support trial, and CPAP trial. And just going with setup, right? For a TPEES trial, the patient's literally disconnected from the ventilator and hooked up to humidified oxygen. For the pressure support trial, the patient remains on an inspiratory pressure and a PEEP. And for a CPAP trial, the patient just remains on PEEP. So from a support standpoint, a TPEES trial, there's no support. There's no PEEP, no inspiratory pressure. For a pressure support trial, there's inspiratory support and PEEP. And then for a CPAP trial, there's just PEEP. There's no inspiratory support. So the physiology here for TPEES trial is, post-extubation conditions. People will say a TPEES trial is closest. We actually disagree with this because it doesn't account for the resistance of the endotracheal tube. For a pressure support trial, it accounts for tube resistance, so it's arguably the most realistic. And then for a CPAP trial, it just has PEEP. It's maybe like in the middle there somewhere. Advantages for TPEES trial, it's simple, no ventilators needed, but the patient was already on a ventilator, so is that a real advantage? Probably not. Pressure support trial, it's most commonly used, it's most comfortable for patients, it's easy monitoring, and there's the most evidence behind it. And then for a CPAP trial, you at least maintain alveolar recruitment and prevent atelectasis because they're on PEEP, although you don't prevent any inspiratory pressure to get over that endotracheal tube resistance. Disadvantages for TPEES trial: increased work of breathing, overestimates failure, not supported by the evidence, requires disconnection from the ventilator. Disadvantages to a pressure support trial is, it may underestimate extubation difficulty because you do get a little inspiratory pressure support, although that theoretically, if it's low enough, should just be enough to get over the resistance of the endotracheal tube. And then CPAP trials, disadvantages are they're less well validated. People just haven't looked at them as much. Common use, we would say TPEES trials, much less commonly used today. Pressure support trials, widely used. CPAP trials, not commonly used. And then evidence, there's most evidence supporting pressure support trials, much less evidence supporting CPAP or TPEES trials. All right, let's get into some practice questions. If you have not participated in practice questions in one of our episodes before, the structures will read the question, we'll read the answer options, and then we actually just go right into the answer. So if you need more time to think about it, just pause the episode because we're going to jump right into the answer. So question 1, beginner, there will be 3 questions. Which of the following is the primary purpose of spontaneous breathing trial? A, to reduce sedation requirements. B, to evaluate readiness for extubation. C, to measure lung compliance, or D, to prevent ventilator-associated pneumonia? Pause here if you need to. The answer is B, to evaluate readiness for extubation, right? Every patient should be having a spontaneous breathing trial every day to determine if they might be ready for extubation. All right, question number 2, intermediate. A patient is on a pressure support of 5 centimeters of water, a PEEP of 5, an FiO2 of 40% during their spontaneous breathing trial. After 1 minute, their respiratory rate is 30 and their tidal volume is 300. What is their RSBI and does it suggest success or failure? So we'll do the math with you here. So RSBI, rapid shallow breathing index, equals respiratory rate divided by tidal volume in liters. This patient's respiratory rate was 30 and their tidal volume was 300 milliliters, which is going to be 0.3 liters. 30 divided by 0.3 hopefully is 120 maybe? Uh-oh. Did we do our math wrong? Good thing we have a calculator right next to us on our phones. 30 divided by 0.3 is 100. I actually think we might have done our math wrong for the answer. So it should be 100, which is B. Less than 105 is most likely success, but it's kind of right on the border. But did we put, yeah, we did. We put C, but that's not true. We just did our math wrong. Good thing we got to explore that together. So the correct answer is B, 100, which is borderline. It still meets, right? Less than 105 is that magic number that they used in these RSBI studies. But as we talked about many times, this is just a single data point. It shouldn't be totally dependent on. And then last question, question 3, advanced. In randomized controlled trials, which approach was shown to shorten time to extubation? A, intermittent mandatory ventilation weaning. B, pressure support ventilation with gradual reduction. C, daily SBTs with prompt extubation if tolerated. D, routine use of CPAP trials for 24 hours. Correct answer is B, daily SBTs with prompt extubation. This absolutely is the thing that you should all be focusing on in your ICUs. Give patients, gosh, we are striking out here. We circled the wrong answer on the video. Give patients daily SBTs, right? SBT, SAT for every patient every single day that meets criteria. That improves outcomes. Absolutely, absolutely.
If I could borrow a quick 60 seconds of your time, I wanted to introduce you to a community we're really excited about building, and that is our Patreon community. In this community, you will get access to high-yield medical education posts, ad-free videos, study guides, practice questions, mini courses, book chapters, and much more. You will see that by joining this community, you will get access to the PDFs, the study guides for every single YouTube video. Here's an example of one of those right now. In addition to that, you will get access to mini courses. In these courses, we will have videos, study guides, practice questions, bedside tips and tricks, and 30 practice questions at the end to test your knowledge. In addition to that, we have collections on every major emergency critical care topic that contains videos, medical education posts, practice questions, study guides, all categorized. And lastly, we have book chapters. These book chapters are high-yield clinical reviews, such as this one on the basics of mechanical ventilation. Beyond that, we have ad-free videos, we have practice questions, and we are constantly innovating and integrating new resources for you all. If you have a passion for emergency critical care medicine like us, consider joining this community today. In it, we hope that you will find all the resources necessary to push your knowledge to the next level and really improve the bedside care of these critically ill patients.